Yeah, okay. Morning, everyone. Welcome back to this day. I'm Heather Zah, and great to see so many people here this morning, not shopping yet in Dubai, in Mumbai. We had a fantastic day yesterday, I think you'll agree. Very wonderful presentations, very important discussion, covering very key issues of epidemiology, transmission, equity, and of course the Young Investigators Tournament. And I think today we're in for a similarly exciting day. If we could just get the scientific program. All right, well, those will come. I just want to make one announcement. The Wi-Fi code in here has changed, so if you need to connect, just look at the sides. The Wi-Fi code is written up. There are two poster breaks today. The first is on evolution and epidemiology. The second is on vaccines, therapies, and treatments. And the posters are just next door across the hall. And then for the Young Researchers Tournament, please vote. The voting will close tomorrow, and you vote by scanning the QR code. The winner will be announced tomorrow. So I'm going to hand over to my co-chair for this session.
Good morning. Thank you, Heather. So I think we have an exciting day ahead of us with so interesting sessions. You have them on the program, but we will be reviewing today where we are in terms of therapy, where we are in terms of prevention, the chances that are already licensed, but those that are about to come, not only for infants and children, but also for older adults. We will be reviewing how are we going to implement these opportunities, not only in developed countries, but everywhere, as we have been discussing these days. And I think that, well, we have indeed a super exciting day, and I don't want to be in between what is ahead of us, and just want to call our chairmen for the first session, who are Ruth Carron and Jacob John. So you all know them. Ruth Carron is a pediatric infectious disease physician. She's professor at the Bloomberg School of Public Health. She is part of the Gavi Visa Steering Committee, and well, she has made important achievements in the field of RSV research, and she received the Robert Chanock Award for her contributions in this field. And Jacob John is professor of community medicine at the Christian Medical College in Vellore in India. He's public health physician. He has been working in the development and implementation of different vaccines across the country. He has been involved also in different clinical trials, and he is member of the NITAC in India, and it's also a pleasure to have him as part of this session chair. So thank you very much, and Jacob and Ruth, the floor is yours.
So good morning, everyone. Jacob and I are very excited to chair this session with you. And as you've already heard we're really at a remarkable moment with respect to RSV vaccines and monoclonals. Some wonderful products have been licensed, some, as you'll hear, are in late-stage development. But before we begin, I wanted to share some new information about a very old study, and I wonder if I could have the first slide, please. This is information about the really infamous formalin inactivated RSV vaccine trial in which 2 toddlers died and many other children were hospitalized. Up until 2023, we just knew these children who died as a 14-month-old and a 16-month-old, and everybody in the field, despite the fact that we did lots of work to try to understand the disease enhancement associated with FIRSV, that was all we knew about these children. And in 2023, a young reporter who had a young child himself, a man named Michael Schulson, decided that he wanted to know more about the history of RSV vaccine development. And so he dug into this and produced a remarkable article. The QR code is there. And what he found out was, first he found the children's names, and then he also found out that it was very unlikely that the parents of these children were ever told why they died. So I think that everyone in this room should scan this QR code and read this article. I've made a promise to myself that whenever I'm in a position to chair a session such as this, that I will speak their names, Ross Hambrick and Victor King. And I hope that you will think about telling these stories when you are in similar positions. The other thing I just wanted to say is that as we move forward, you know, the data we're going to hear and the studies that are being done are remarkable and exciting, but we have to not forget to be careful, thoughtful, and above all, humble in what we do, because we don't always know as much as we think we know. So with that, we are going to begin. I would like to ask Buki Adoko from Sanofi to come to deliver the first talk. This is live attenuated RSV vaccine for the prevention of RSV disease, is safe and immunogenic in 6 to 18-month-old children. Buki.
Hello? Okay. Thank you, Ruth, and good morning, everyone. I'd like to start by thanking RSVNet for the opportunity to present our data here today at this Congress. And I present on behalf of a large group of investigators and Sanofi staff who have worked on this VAD01 clinical trial. So this is a live attenuated RSV vaccine for the prevention of RSV. And we present our safety and immunogenicity data in 6 to 18-month-old children. Next slide, please. Can I move the slides from here? Okay. So this is my conflict of interest statement. I currently work for Sanofi, and this trial was funded by Sanofi. So as I'm sure everybody in this audience knows, RSV occurs across the life course, with the burden of disease being in infants and the elderly. But just to highlight here that the burden doesn't go away after the first 6 months, but persists into infanthood and early toddlerhood, with persisting lower respiratory tract disease and that burden of outpatient illness as well in that age group. At Sanofi, our approaches for infant and toddler immunization include the MAB, which most of us have heard a lot about and which has been recently introduced in several countries across the globe. This monoclonal antibody was jointly developed with AstraZeneca and is targeted at infants for the prevention of RSV for all infants for their first RSV season and for children with comorbidities into their second season. So in addition to this monoclonal antibody, we have the live attenuated RSV vaccine, which is being developed as a collaborative research and development agreement between Sanofi and the National Institutes of Allergy and Infectious Disease in the US. This vaccine targets infants before their second RSV season and is delivered intranasally with a target age group of infants greater than 6 months of age. So just a little bit about the vaccine. There are two deletions, the NS2 deletion, and this deletion attenuates the virus, removing the risk of NS2-mediated airway obstruction, which is a significant presentation of RSV in children this age. And the deletion of the NS2 gene also improves the immunogenicity, leading to effective viral clearance. In addition to the NS2 deletion, there's also the 13-13 deletion and the 13-14 insertion, which confers a temperature-sensitive phenotype as well, and the insertion stabilizing this deletion. So the specific study in question, this is our VAD0001 study, conducted in infants in the US and in Chile and Honduras, so North America and South America here. We recruited participants into this study in 4 sequential cohorts to receive either an increasing number or increasing or higher dose of the vaccine. So participants in cohort 1 received the low dose formulation of the vaccine, and they received 1 dose. Following a safety review, we then recruited participants into cohort 2 to receive 2 administrations of the low dose formulation. Following safety review, participants were then recruited into a third cohort where they received 1 administration of the high dose formulation. And participants in cohort 4 then received 2 administrations of the high dose formulation, 2 administrations of the low dose formulation, or placebo in parallel. So this is the cohort that we utilize for our comparisons as we recruited low dose, high dose, and placebo recipients in parallel into this cohort. A little bit on the study design. Participants received, as I mentioned, 2 administrations, and the design up on the screen here is for the participants in the 2 administration cohort. Participants in the 1 administration cohort had similar, except that they didn't get the second dose of the vaccine. So participants received 2 administrations of the vaccine 2 months apart and had blood samples for immune assessments at baseline 28 days after, just before the second dose, 28 days after the second dose, and either at the end of the subsequent RSV season or 5 months after their last vaccine administration. We also collected nasal swabs 7 days, roughly 7 days after each vaccine administration to assess vaccine viral shedding post-vaccination. And the safety assessments are as depicted on the slide. So our main objectives really were to, 1, assess the safety of this candidate after each dose in all infants and toddlers, regardless of their serostatus, and to assess the RSVA serum neutralizing antibody responses in each of the study groups in RSV-naive participants. So in the participants who received 1 administration in all 4 cohorts, and after their second vaccine, for those who received 2 vaccine administrations, and that's the participants in cohorts 2 and 4. But as I mentioned, I will focus this discussion on participants in cohort 4, which was the cohort in which we had participants recruited to all dose levels in parallel. So safety data. We had transient rhinorrhea and nasal congestion occurring commonly after each vaccination. Rhinorrhea was slightly less common in placebo recipients, particularly following the first vaccine administration. So in the figure on the left, we have the vaccine administration site reactions after vaccination 1, and on the right, we have the administration site reactions after vaccination 2. Slightly less reactions after vaccination 2, but pretty similar between the 2 dose levels, the low dose and the high dose recipients. The systemic reactions solicited post-vaccination. These included fever, vomiting, abnormal cry, drowsiness, appetite loss, and irritability. And systemic reactions were generally more common after the first vaccine administration than the second. Irritability was the most common systemic reaction reported, and appetite loss was reported frequently as well. We elicited robust immune responses were elicited following administration of the vaccine. On the graph here, we have the GMTs, geometric mean titers, pre-vaccination at day 56, which is just before the second vaccine administration, day 84, 28 days after the second vaccine administration, and either at the end of the subsequent RSV season or 5 months after their last vaccine administration. And we see that increase in the GMTs there from the baseline values to the 28 days post-second vaccine administration, and the persistence of those antibodies out to the end of the subsequent RSV season. We also assessed the fourfold or higher rise in neutralizing antibody titers, particularly after each vaccination. And we see here the robust fourfold rise in neutralizing antibody titers after the second vaccine administration. So on the left, we have the percentage of participants attaining a fourfold or higher rise in neutralizing antibody titers after the first vaccine administration, in the middle after the second, and then we also assess the responses after one or two vaccine administrations. And after two vaccine administrations, we have well over 60% of participants attaining a fourfold or higher rise in neutralizing antibody titers. And if we look at either post either administration, that's roughly 70% of those participants. And we just wanted to point out here that this fourfold or higher rise in neutralizing antibody titers in RSV-naive toddlers has previously been associated with protection from disease in studies conducted by Ruth Karen and her group assessing several live attenuated vaccine candidates. As we also assessed vaccine viral shedding after each vaccination, we have on this graph the vaccine viral shedding following the first vaccine administration, the second vaccine administration, and also following the second vaccine administration in the population of participants who attained a fourfold or higher response in neutralizing antibody titers, whom we've tagged here as responders. So following the first vaccine administration, we have close to 55% of participants at either dose level, low dose or high dose, attaining a shedding vaccine virus. After the second vaccine administration, we see that significant drop in the number of or the percentage of participants shedding vaccine virus. And this is slightly lower if we look at just those who attained a fourfold or higher rise in neutralizing antibody titers after their first vaccine administration. So this data does suggest that there is priming of the immune system with our candidate, and we hope to be presenting more on the shedding data at an upcoming Congress. So our conclusions. The intranasal route provides a viable option for RSV vaccines. It mimics natural infection and therefore may provide added benefit. It's also attractive as it avoids an additional injection in what is an already crowded immunization schedule. There were no safety concerns in this phase 1/2 trial. Rhinorrhea and nasal congestion were slightly more common in vaccinees than in placebo recipients. Robust immune responses were elicited at both dose levels after two vaccine administrations, and these do persist up to 5 months post the second vaccine administration. And this aligns with, as I mentioned, an early efficacy trend from other trials with other live attenuated vaccines, including this candidate. So the response to the first vaccination does seem to offer some protection from shedding vaccine virus after a second vaccine administration. And this suggests priming of the immune system. So this strong safety and immunogenicity data from our study support further development of the candidate. And as a team, we're very excited to announce that based off this data, we have just started our phase 3 program with the first participants recruited into our global phase 3 efficacy trial on the 6th of February, so just in time for this Congress. I'd like to acknowledge all the partners from the NIH. As I mentioned, this candidate is being developed as a CRADA with the NIH. So Ula, who's unfortunately unable to make it to this meeting, and her team at the NIH, with Karen and the group at Johns Hopkins, and all our investigators who are listed here on the screen, and all my colleagues from Sanofi, some of whom are present in the room, and all the trial participants who have participated in this trial. And thank you for your time.
So thank you so much, Buki, and congratulations to the team. This talk is now open for questions. I see Keith coming to the microphone. Please.
Thanks so much for a lovely presentation. There was one thing that was totally intriguing, which you have to explain to us. How did one of the placebo group get to be colonized with the vaccine virus?
Thank you for that. This is a point that I omitted to mention on that slide. This is unexplained really to us. We have tried to dig in to see if there was contact with a vaccinee or possible exposure on site, so the honest truth is we don't know. Our assay is quite specific, but that was what we found. Thank you.
Hello, impressive results. Alex Orrico from Fisavio in Valencia. I would like to know if you think that we could introduce some kind of pressure into the virus that could favor the mutation, and if so, with the international, situation that, of course, decrease the shedding, and if so, it would be easy for you to change and to adapt the vaccine easily?
So, I'm sorry, I'm not sure I completely get the question.
I think it was a question about mutation of the virus over time and whether that was a risk.
So the vaccine virus is quite stable. We are, however, currently gathering data on that particular point in a transmissibility study which we're conducting. We're looking at transmissibility of the virus and stability of the shed vaccine virus. But from the previous work that has been done on this candidate, it does suggest that it is quite stable and that this is unlikely. Yeah.
Oh, and maybe just additional comment on that. This is a deletion mutant, so it is missing the NS2 gene. And these negative stranded viruses, to our knowledge, don't recombine. So that's the other reason. There could be instability of a point mutation, which this vaccine also contains, but probably not of the deletion mutation. So yes, please.
Very nice talk. The nasal contents are emptied every 20 minutes. So does your vaccine have formulations with mucoadhesion to increase the persistence of the antigens in the nose or the virus in the nose?
So it is a good point. We have seen that in spite of that particular fact that yes, nasal contents are emptied very frequently, we are eliciting immune responses in these participants. For the early trials, we have avoided vaccinating children who have an active respiratory tract infection. That's the only precaution we've taken to date. But we are seeing responses there. Thank you.
Good morning, Doko. Very nice data, and congratulations. Pedro Piedra from Baylor College of Medicine, Houston, Texas. My question is, you demonstrated that the high dose elicited, I think, a more robust pre-F, I think it was IgG, or I don't recall if it was IgA, ELISA antibody response. But when compared to the lower dose. But when you looked at fourfold rises, they were relatively comparable. And so I wonder if you can comment on the geometric mean titers that the high dose versus low dose achieved.
We interpreted them as pretty comparable between the groups. If we look at those confidence intervals, there were slight differences between the high dose and the low dose, like you mentioned. But these were overall generally quite comparable between the two doses.
Thank you.
Marta Tufet from Gavi, the Vaccine Alliance. Congratulations on the success of your study. I was wondering whether you would be able to share where you will be conducting your phase 3 efficacy trial. Thanks.
So for the phase 3 efficacy trial, we are conducting a global trial. I can't give you all the countries off the top of my head, but on at least 4 continents. So we have sites in North America, in South America, in Asia, and in Africa.
Thank you.
Hi, very nice presentation. Mauricio Caballero from Argentina. Do you measure immune cell response in this trial? T cells respond or?
T cells, no, we do
No?
not.
Okay.
No, we don't.
Thank you.
We know the challenges with doing that in this age group, so no, it's not something we've done. Thank you.
Thank you very much. So we'll move on to our next presentation, and there are very nice bios of each of the individuals, but I'm not using them because I think it's better to have more time for discussion. So this is Niranjan Kanasathasan from Icosavax discussing safety and immunogenicity of an RSV and HMPV bivalent VLP protein subunit vaccine in older adults. Please.
Thank you. Hi, I'm Niranjan Kanasathasan. I'm the Chief Medical Officer of Icosavax, and I'm pleased to present and have the opportunity to show our top-line interim phase 1 data of IVX-812, which is our virus-like particle, or VLP for short, combination vaccine candidate against RSV and human metapneumovirus, HMPV, in older adult participants. My disclosures are shown on this slide and here. RSV in older adults, I don't have to tell this audience, is increasingly recognized as one of the top 5 pathogens detected in adults hospitalized for pneumonia. Based on the literature and expert opinion, HMPV has fairly similar epidemiology, clinical presentation, and disease burden in older adults. When assessed in the same prospective surveillance or retrospective reviews studies, HMPV typically appears right after RSV in terms of incidence and disease burden. Consistent with our view when starting Icosavax, RSV vaccination recently received an ACIP recommendation for older adults in the U.S. based on 80% reductions in lower respiratory tract infection. There's currently no licensed intervention for HMPV. We believe that the story of HMPV vaccine may unfold similarly to that of RSV over the next several years. IVX-812 is a potential first-in-class combination vaccine candidate addressing a significant unmet medical need by targeting RSV and HMPV, 2 leading causes of pneumonia in older adults, in a single shot. RSV and HMPV are viewed as genetically related viruses. They behave in a similar way, including having a fusion or F protein target that undergoes a conformational change from its pre to post-fusion structure upon fusion to the cell membrane. As we've heard, many RSV vaccines utilize pre-fusion F antigens based on the work at NIH of Drs. Graham and McClellan. Our IVX-241 VLP for HMPV displays another highly engineered, stabilized pre-fusion F antigen developed by Dr. McClellan. Those of you familiar with our story have also seen our preclinical data for IVX-241 HMPV VLP, as well as for our IVX-812 combination vaccine, which both completely protect against viral replication in the lung. In terms of RSV VLP, called IVX-121, in 2022, we reported positive 1-month RSV immunogenicity data and 6-month immunogenicity durability data from a phase 1/1b clinical trial. We believe the IVX-812 combination vaccine to be unique in the field and the most advanced in clinical development for both RSV and HMPV in older adults. And IVX-812 received Fast Track designation from the FDA in 2023. Moving on to the study, the phase 1 trial was a randomized observer-blind, placebo-controlled dose ascending trial, which evaluated the safety and immunogenicity of IVX-812 in older adults. Let me start with an overview of the trial, which enrolled older adult participants 60 to 75 years of age across 5 IVX-812 treatment groups and placebo. There were 140 participants in the safety analysis set, with 123 evaluated on days 0 and 28 for immunogenicity. I'd like to call your attention to the top right of this slide, which describes the dosage levels tested in terms of total VLP content that we will use throughout the discussion. The three dosage levels range from 150 to 300 micrograms total VLP dose, with a fixed 75 microgram dose of RSV VLP combined with either 75, 150, or 225 microgram dosage levels of HMPV VLP. These correspond to the low, mid, and high dosage levels, respectively. This design allows us to assess possible immune interference as we increase the HMPV VLP content with ratios up to threefold relative to RSV VLP. The 75 microgram RSV VLP is a middle dosage level studied in our prior monovalent IVX-121 phase 1b trial in older adults. Note that the 75 microgram dosage level for RSV VLP is equivalent to approximately 42 micrograms of RSV pre-F antigen. For reference, other RSV vaccines have pre-fusion F content of 120 micrograms. The study design shown in the top left panel shows these three dosage levels were tested in two formulations as an unadjuvanted combination of the two VLPs for all three dosage levels and as an adjuvanted formulation with MF59, Seqirus' proprietary oil and water emulsion adjuvant for the low and mid-level dosage levels. Placebo recipients were also randomized as controls. All participants received a single intramuscular dose of assigned vaccine or placebo. Participants were observed for 7 days following their dose for solicited adverse reactions, as well as for 28 days for unsolicited and other adverse events. Immunogenicity was assessed at days 0 and 28, including neutralizing antibodies to RSV-A, RSV-B, HMPV-A, and HMPV-B. All neutralizing antibodies were measured in validated assays. As with IVX-121, we will show RSV-A and RSV-B responses in standardized international units, or IU per mil, using a WHO reference sera. There's currently no equivalent international reference sera for HMPV, so responses are expressed as assays, units per mil. With that, let me turn to the interim safety and immunogenicity data. In this overall interim safety data, IVX-A12 was generally well tolerated in a combined safety population of 117 older adult patient participants exposed to IVX-A12, compared with a placebo group of 23 participants. There were no serious adverse events, clinical events of special interest, or adverse events leading to study discontinuation. On this overview slide, you can also see that unsolicited adverse events were mild to moderate in nature and occurred at similar frequencies to that seen in placebo recipients. The single severe unsolicited adverse event was unrelated to IVX-A12 vaccination. Oops, struggling here. Moving on to more detail on local and systemic adverse reactions. Looking first at the left-hand panel at local solicited adverse reactions, unadjuvanted IVX-A12 showed predominantly mild adverse reactions across the three dosage levels, while there was a slight increase in the adjuvanted group, as expected. These adverse reactions were typically transient in nature. On the right-hand panel, we see the systemic solicited adverse reactions for the same groups is mild to moderate in nature, with a frequency of 25 to 41% overall in IVX-A12 vaccinees, similar to 35% in placebo recipients. There were no severe systemic solicited adverse reactions observed. We're pleased with this safety data, which is similar to what we saw before for IVX-121. IVX-A12 does not show any dose-limiting reactogenicity up to the highest dosage level tested of 300 micrograms. Moving now to the interim immunogenicity data, this first slide presents the interim RSV-A and RSV-B neutralizing antibody data in IU per mil by dosage level, with the unadjuvanted IVX-A12, on the leftmost part of the x-axis, the adjuvanted IVX-A12 groups in the middle, followed by placebo group on the right. In the furthest right part of the x-axis, we have also included a sera reference panel shown in orange, drawn from participants in the IVX-121 phase 1b trial, who received an equivalent 75 microgram monovalent RSV dose. Remember that the RSV-VLP dosage is fixed across all these groups except for placebo. So what varies is the concentration of HMPV-VLP and the absence or presence of MF59 adjuvant. In the left panel, we show data for RSV-A neutralizing antibodies at day 0 in the light blue and 28 in the dark blue following vaccination. The geometric mean titers, or GMTs, at baseline before vaccination at day 0 and at 28 days after vaccination are shown as bars on the graph. By day 28, these GMTs increased in all IVXA-12 treatment groups with GMT up to 16,100 IU per mil. The right panel shows RSV-B neutralizing antibody responses, again in IU per mil, and reveals a pattern of immunogenicity similar to RSV-A after IVXA-12 vaccination. By 1 month after dosing, GMTs were boosted up to approximately 8,300, 8,300 IU per mil in the IVXA-12 treatment groups. These GMTs exceeded those seen with the same monovalent RSV dosage level in the IVX-121 trial after vaccination. The most important observation from these interim data is the absence of immune interference from the combination of HMPV-VLP with RSV-VLP. The GMTs for RSV neutralizing antibodies at day 28 were high and relatively flat across the 5 IVXA-12 treatment groups, despite increasing concentrations of HMPV-VLP or adjuvant in the formulation. Many other participants in our trial had remarkably high baseline GMTs for neutralizing antibodies before vaccination. We believe that the resulting geometric mean fold rises, or GMFRs, are lower, up to 4-fold for RSV-A and 3-fold for RSV-B because of these high baselines. As we said before, we believe it is the absolute titers in international units following vaccination, not the GMFRs, that are the most associated with protection. The next slide shows the interim HMPV-A and HMPV-B neutralizing antibody data in assay units per mil per dosage level, with the 5 IVXA-12 treatment groups and placebo groups on the x-axis. In these graphs, we don't include the sera from participants in the IVX-121 phase 1b trial who received an equivalent 75 microgram RSV dose, as there was no observed HMPV-A neutralizing antibody response in that trial. We're very excited by these data, which show the first evidence of HMPV immune response following vaccination of older adults. As a reminder, no standardized sera or international units exist for HMPV. In the left panel, we show data for HMPV-A neutralizing antibodies at days 0 and 28 following vaccination. Participants in our trial had neutralizing antibody responses observed across all IVXA-12 treatment groups, with GMTs up to 3,300 assay units per mil and fold rises up to 5 times baseline titers after vaccination. There was no apparent dose response on HMPV-A neutralizing antibody titers with increasing HMPV dosage level. The pattern of responses was similar to that seen for RSV. The right panel shows HMPV-B neutralizing antibody responses, again in assay units per mil. By 1 month after dosing, GMT of neutralizing antibody responses to HMPV-B were boosted up to 24,000 assay units per mil in the IVXA-12 treatment groups alone. GMFR of HMPV-B neutralizing antibodies ranged up to 4-fold after vaccination and were comparable to those seen with HMPV-A. There was no apparent dose response on HMPV-B neutralizing antibodies with increasing HMPV dosage level. The key takeaway here are robust immune responses to both types of HMPV after IVXA-12 vaccination, following a very similar pattern to what we just showed you for RSV. Across these groups in the 2 HMPV types, we see relatively flat GMT with up to 4 to 5-fold GMFRs, despite some variability in baseline titers. The variation between HMPV-A and HMPV-B assays is an example of why it can be difficult to compare titers across studies without the benefit of standardized international units. We intend to complement our upcoming clinical work on IVXA-12 with additional work to help establish the epidemiology, attack rates, and burden of disease of HMPV all work that was similarly done to demonstrate the need for older adult RSV vaccination. Please see our conference poster on a systematic literature review of HMPV epidemiology and the burden of disease in older adults. Based on our experience with the potential impact of baseline titers on immune response to vaccination from our IVX-121 phase 1b trial and coming out of a pandemic, we plan pre-specified subset analyses on how participants with lower baseline titers, the population that benefits most from vaccination, responded to IVX-A12. I will walk you through those right now. Here we're looking at participants with the lowest tertile of baseline antibody titers for RSV-A and RSV-B. We're showing pooled adjuvanted and non-adjuvanted groups for the low and mid dosage groups in this analysis due to comparability of their responses and to increase the number for this tertile analysis. For both RSV-A and RSV-B, we see a similar pattern. For these participants with lower baseline titer, we see GMTs of up to approximately 8,000 and 5,000 IU per mil, with fold rises of up to 11 and 7-fold for RSV-A and RSV-B, respectively. These data suggest that the participants with the lowest baseline antibody titers, who are also those most at risk for infection, see a strong response to our vaccine. And importantly, we see these results with a modest RSV antigen dose. It's a similar story with HMPV. When we look at participants with the lowest tertile baseline titers, we see a robust response to our combination vaccine with GMTs up to approximately 2,600 and 20,000 assay units per mil, with fold rises up to 9 and 8-fold in HMPV-A and HMPV-B, respectively. In conclusion, IVX-A12 shows good preliminary safety and reactogenicity up to the highest dose tested. We have a long way to go, but we believe that this attribute provides flexibility as we select doses for phase 2 and beyond. We're thrilled that IVX-A12 induced robust day 28 neutralizing antibody titers against both RSV and HMPV. As many of you will recall, our key aim in this trial was to look for any immunointerference using different ratios of RSV and HMPV VLPs in the same vial, so that we could select 2 formulations to test with a larger sample size in a phase 2 dose optimization trial. I'm pleased to share that there is no evidence of immune interference. With IVX-A12, we actually saw higher post-vaccination levels of RSV-A and B antibody titers in international units than we saw in our previous clinical trial of IVX-121, our monovalent RSV vaccine alone. Based on our experience with the potential impact of variable baseline titers on immune response or to vaccination from our previous phase 1b trial and coming out of an atypical COVID-19 pandemic, we pre-specified subset analyses to look at participants with lower baseline titers. In this group, where baselines were closer to other RSV trials reporting in international units, the change from baseline, or GMFRs, for RSV-A and B were up to 11 and 7-fold, respectively. For HMPV, the GMFRs in the corresponding subset analyses for HMPV-A and B were up to 9 and 8-fold, respectively. We're excited about this data on HMPV. As many of you recall, we were looking for a similar pattern of immune responses in HMPV at day 28 to what has been seen with RSV, and that's what we believe we saw in phase 1. These data from our pre-fusion F VLP for HMPV, combined with the clinical validation of the pre-fusion F approach to RSV, give us confidence as we advance IVX-A12 in development. To our knowledge, the top-line interim phase 1 results we shared today also represent the first clinical data in the vaccine field for HMP vaccination in older adult populations. We now have an ongoing phase 2 safety and immunogenicity trial in older adults that I've already mentioned, intended to select a final formulation for future clinical development. Thank you for your attention. I'd be happy to take questions.
Thank you. This is open for questions, and I think while people approach the microphone, I'll take Chair's prerogative and ask a couple. One is that when you look at the whole population, it seems that MF59 doesn't really add anything. Is that true also when you look at the subset of people with lower baseline titers? Is that true?
Yes, that's a great question. In fact, that was one of the other reasons we pre-specified the analysis to see if there was a favorable effect of MF59 in those individuals who had lower baseline titers. We did not see that.
Okay, thanks. And is the HMPV-F that is in the VLP HMPV-FA? And the question is it just sort of an artifact of the assays that for HMPV-B you get a log-fold greater titer in general? Do you think that's just an assay issue?
So two questions there. It is the antigen for HMPV VLP is based on HMPVA, Netherlands strain prototype. And with regards to the variability in the assays, I think it's an assay question until we kind of get up to speed.
Okay, thanks. Tony, please.
Narajan, again, congratulations on, I would say, next generation RSV human metapneumovirus vaccine.
Thank you.
It looks like you've reached a plateau, at least for human metapneumovirus. But what I want to do is go to RSV, and an area that you didn't talk about was the issue of site-specific responses. And I was wondering if you can comment on what type of site-specific response the vaccine is inducing.
Yes, thanks, Tony. We did not, well, we do have data on competition ELISA. So we had two competition ELISAs developed for D25, which is a site 0, and also for palivizumab, site 2 and 4. And we see favorable responses directed to site 0. We saw that in IVX-121. We're completing that analysis in the IVX-A12 data set as well. So we believe we've looked also preliminary, more established for the monovalent trial at binding to NEUT ratios, and we see that those are favorable as well. So we believe the nature of the response we're seeing with the VLP approach is directed towards site 0.
Thank you.
We'll be continuing our analysis. Thank you for the question.
Jaya Goswami from Moderna, great data. Congratulations. So two questions. Can you speak to the comparability of the 75 microgram in VLP to the 120 microgram protein vaccine, subunit vaccines? Is there any comparability other than immunogenicity?
You mean in terms of antigen content? Mm-hmm. So we have approximated the amount of DS-CAV1 type antigen, prefusion antigen, on the surface of the VLPs as approximately 42 micrograms in that 75 microgram dose. So there's some evidence for being less than the total amount delivered with the subunit approach.
And the second question is regarding the RSV-A neutralizing antibody titers at baseline. These are ID50, I'm assuming. And you see quite a bit of high baseline titers. Can you speak to that data?
Yes, I think they've switched my slides, but there is actually a slide, I'll just say it verbally. So we saw much higher titers, as you saw with the reference panel from our monovalent study. So we investigated further, and so the trial was done in September of 22. There was a very high RSV appearance, and actually we could track it because most of our participants who were enrolled were in Florida, which happens to report individual RSV positive data. So I wish I could show you the slide, but I'm happy to do that later. But what happened in that year was there was a late peak starting in March through May of the year, which started to come down just before we started our trial in September. So we believe that's at least part of the attribution for the high baseline titers we observed. The other rationale we saw was it was a dose ascending study. So as people got enrolled and vaccinated later in this trial, we saw lower and lower step down on baseline titers.
Thank you.
Thank you, Dr. Ganesan. So for RSV is a formidable problem, and having more solutions is a great thing. And I think we are at exciting times. So we'll move on from vaccines to now looking at an RSV fusion inhibitor. Please welcome Dr. Seema Chusi from Pfizer. Over to you.
Hi, thank you. Today, I'd like to review the results from a PK and safety study of sisunatovir, a potent RSV F fusion inhibitor in hospitalized infants with RSV lower respiratory tract infection. Here's my disclosure. And the funding was initiated under ReViral, which was acquired by Pfizer in June of 2022. So sisunatovir is an orally administered RSV F protein inhibitor. It acts by targeting the viral host cell fusion, thereby preventing viral entry into the host cell. Sisunatovir has high potency against both RSV A and B strains. In an adult viral challenge model study, it demonstrated high potency and lack of clinical resistance. In that study, there was significant reduction in viral load and symptoms. There was a favorable safety and tolerability profile at the 200 milligram twice daily dose given over the course of 5 days. And at that dose, exposure of above EC90 was achieved. As mentioned, there was no evidence of clinical resistance. Although 3 RSV-F genetic variants were identified, this was not correlated with viral load rebound or the development or progression of clinical symptoms. So the objective for today is to review the single dose and multiple dose study evaluating the safety, tolerability, and PK of sisunatovir in hospitalized infants. The main inclusion criteria for this study included a target population of infants and children 1 to 36 months of age with a clinical diagnosis of lower respiratory tract infection who were hospitalized because of RSV LRTI. For Part B specifically, which was the multiple dose part of the study, there was additional inclusion criteria, a requirement that the RSV-related signs or symptoms not be present for greater than 7 days, and a requirement to be hospitalized for at least 3 days. The key exclusion criteria for both Parts A and B of the study, the single dose part and the multiple dose part, were participants were excluded if they were preterm and less than 1 year postnatal age, if they were known to have significant comorbidities, known to be immunocompromised, or suspected of having clinically significant bacterial infection. So Part A was a single dose part of the study, an open label part of the study, and Part B was a placebo-controlled, double-blind, randomized part of the study where participants were given either sisunatovir or placebo every 12 hours over the course of 5 days. And herein listed are the doses provided, which were weight and age-based dosing. The primary objective of the study was to evaluate the PK, safety, and tolerability of sisunatovir. And recruitment for this study occurred across 16 sites in 6 countries, and the study began in November 2019 and concluded December 2022. In total, there were 50 participants who were administered either sisunatovir or placebo. In Part A, the single-dose part of the study, 19 participants were administered sisunatovir, and in Part B, there were 22 participants who received sisunatovir and 9 who received placebo. The mean age of participants in Part A was 13.4 months and was lower in Part B at 8.4 months. And this is partly due to the proportion of participants who were enrolled in the older age group. So in Part A, there were more participants enrolled in the 6 to 36 month age group as opposed to the 1 to 6 month age group, which was seen in Part B, and I'll share that in a subsequent slide. There was a male predominance for both parts of the study, with 63% being male in Part A and 61% in Part B. The proportion of RSVA strains was similar across both parts of the study, 52 to 58% being RSVA strains. The viral co-infection rate was 19 to 23% across both parts of the study. The most common pathogen detected was rhinoenterovirus, which was identified in 7 participants, followed by adenovirus, which was identified in 3 participants. The symptom duration for Part B participants at the time of first dose was 3.6 days. The figure at the left depicts what evolved in the single-dose part of the study, and it shows the mean plasma cisnatavir concentrations over time for those participants who received a single dose ranging between 1 milligram to 2.5 milligram per kilo. At the right is a figure depicting the multiple dose part of the study, showing the mean plasma cisnatavir concentrations over time for those participants who received doses ranging from 2.5 to 5 milligram per kilo. And with that, in Part B, the steady state trough concentrations with coverage over EC90 was achieved for participants in the 1 to 6 month age group at the 2.5 milligram per dose, 2.5 milligram per kilogram dose, which is shown in yellow. And for those participants, this was in the 6 to 36 month age group, this was achieved at the 5 milligram per kilo dose, which is shown in blue. In the next couple of slides, I'll review the safety summaries for Part A and Part B. In Part A, Cohort 1 was a 6 to 36 month age group, and 3 doses were evaluated. In Part A for Cohort 2, that was the 1 to 6 month age group, and 1 dose was evaluated. Each column depicts the dose provided with a number of participants, with E indicating the number of events. In Cohort 1, the first dose to be evaluated was a 2.5 milligram per kilo dose. And in that dose group, there were 3 treatment-related adverse events of vomiting that occurred for those 3 participants. And that was attributed to cisnatavir being suspended in water as a diluent. Subsequently, further dosing in Part A was done with either formula or breast milk, and there was no further episodes of vomiting. There were 2 other treatment-related adverse events in Part A, and that occurred in a 2 milligram per kilo dose group in Cohort 1. One was an adverse event, a moderate adverse event of thrombocytosis, and there was 1 participant with a mild adverse event of sinus arrhythmia. That participant was an 18-month-old infant who had no correlating clinical symptoms. The same ECG was read centrally by a pediatric cardiologist as normal with no findings. There was 1 SAE in Part A, and that was an SAE of pyrexia, which lasted less than 2 hours, but it was considered serious as it did prolong hospitalization. All treatment adverse events in Part A were mild or moderate intensity. In Part B, similarly, all treatment adverse events were of mild or moderate intensity. There were no severe adverse events and no serious treatment emergent adverse events. There were 3 treatment emergent adverse events that were considered related to cisnatavir. 1 was a mild treatment adverse event of thrombocytosis, which occurred in Cohort 3 at the 2.5 milligram per kilo group. There was a second treatment-related adverse event of diarrhea that occurred in the 1 month to 6 month old age group at 2.5 milligrams per kilo. And that incidence of diarrhea occurred in a participant who was in the ICU on mechanical ventilation receiving TPN. The third adverse event that was considered treatment-related was an episode of vomiting that occurred in the dose group that received 5 milligrams per kilo. And that occurred in an infant on day 1 with the first dose and ultimately led to study drug discontinuation due to parental request. There were no other study drug or study discontinuations in Part B. In this study, there were no emergent substitutions observed in RSVF protein. The RSV viral load was analyzed by real-time PCR and nasopharyngeal samples collected throughout the study. Overall, the mean RSV viral load decreased post-dose in all groups. However, due to the limited sample size, the study was not powered to evaluate and compare viral load declines between cisnatavir and the placebo group. RSV F protein gene sequence analysis was performed on nasopharyngeal samples from Part B participants. There were no post-baseline F protein emergent substitutions observed, and no F protein resistance-associated substitutions identified in samples from any participant. In conclusion, the single and multiple dose cisnatavir in children 1 to 36 months of age hospitalized with RSV lower respiratory tract infection was safe and tolerated at doses above in vitro EC90. Doses that were deemed, exposures were deemed effective in the adult challenge study, suggesting a favorable therapeutic index. The small sample size did not allow for meaningful evaluation of changes in symptoms or viral load, but importantly, no treatment emergent substitutions in the RSV F protein were detected. The safety, tolerability, and PK data supports further development of cisnatavir in pediatric participants with RSV infection. And with that, the next steps include an ongoing multicenter phase 1b pediatric study evaluating the optimal dose of cisnatavir in pediatric patients up to 60 months old with RSV LRTI. And this study is currently being conducted with investigators across 10 countries. I'd like to thank the many investigators who are involved in this study and the many colleagues across Reviral, Syneos, and Pfizer who contributed to the study and its completion. And most of all, many thanks to all the pediatric patients and families who participated in this study. Thank you.
Ruth, you had a question?
Yes, thank you for that very nice presentation. I'm wondering about, if I understood it correctly, the choice of timing for beginning this drug. So if I understood correctly, I think you said it was children who'd been hospitalized for 3 days. And at least my understanding of RSV viral replication kinetics is that the peak of viral replication is substantially before that. In fact, it may even be before the children are hospitalized. A lot of what you see in hospital is the immune response. So I'm just wondering about the thinking around the timing and whether you might consider in future trials actually giving this drug sooner. Thanks.
Yes, absolutely. It's a great point. So this study was primarily, Part A and B was conducted to evaluate the safety and tolerability of cisnatavir and not necessarily the efficacy and evaluate viral load reduction and impact on symptom resolution. So given that, we allowed a longer window for recruitment into the study. Part A, there was no symptom window. It was a single dose part of the study, and for Part B, it was 7 days, but I agree that that does, ideally, if you were looking to evaluate viral load kinetics and symptom resolution, you would want to recruit them earlier. So definitely we'll keep that in mind for future studies. Thank you.
Thank you very much. Very interesting. Aurelio Bonavia from Gates MRI. I was wondering, if I remember correctly, there was some resistant viruses done in vitro early in development. There was a paper, I believe. Can you comment on any resistance with this molecule in vitro?
So the challenge model study did identify in 3 participants that there were 3 participants who had mutations identified in the RSVF protein, but there wasn't an association that indicated, it was not correlated with either a viral load rebound or clinical failure. And for this study, the other study that was evaluated, there was no emergence of RSVF protein substitutions or resistance.
Right. I'm asking for in vitro.
Oh, in vitro.
In vitro work, because I understand that this is a small size.
So there is ongoing in vitro work, and to date there has been no evidence of mutations that I'm aware of.
Well, that's great for a future inhibitor.
Yeah, thank you.
Thank you for presenting your data. These are always very difficult studies to do. So, did you see any viral rebound after you stopped cisnatavir?
For the pediatric study, did we
Yes.
see? So the viral load data that was available was very limited, but we did not see viral load rebound. There was a gradual decline over time, but it was only up until, for Part B, viral load was only collected up until day 7.
That was going to be my second
Yeah.
question. How far out were you able to look at mutations occurring?
Yes, it was only looking out
I
to
see.
day 7.
Okay,
So,
thank you.
yeah, thank you.
Thank you, Dr. Tuzi.
Okay.
So we move our attention to a newer monoclonal antibody, and we welcome Dr. Anishwa to talk about clesrovimab from Merck.
Good morning. I'm Anishwa Sinha, and I'm the product development team lead for clesrovimab. It's my pleasure on behalf of the authors listed here to present our phase 1b/2a single ascending dose study, our first in infant study. The results we're presenting today are our final results. For those who were present at RSVVW'23 in Lisbon, we presented our interim analysis results there. These are my disclosures. We had a robust and full session yesterday led by Harsh and Varsha on the disease burden in infants and adults. And needless to say, RSV remains an important unmet medical need globally. It's with this in mind that we're developing a single once-a-season monoclonal antibody as a preventative for all children, all infants. Having said that, let me turn to some background on clesrovimab. The figure on the right shows the crystal structure of the pre-fusion conformation of the RSVF protein. You see that in yellow. And it illustrates in blue clesrovimab bound to site 4. You see the monoclonal antibody bound to 2 of the 3 sites on the trimeric F protein. Site 4 is a highly conserved epitope, which is to say it has a very low rate of mutations detected within its binding site sequences. Clesrovimab has demonstrated high potency against a range of RSV clinical isolates, and it's equipotent against both RSV A and B. It has 3 engineered substitutions in the FC, that is to say the constant region of the monoclonal antibody, and these result in increased recycling of the antibody and hence an extended half-life in blood. So with that background, let me turn to the results of this phase 1b/2a study. Please bear in mind that while I'm sharing these 1b/2a results with you, this product is currently in phase 3 of development with 2 late-phase studies in the field. So here's the study design. The 1b/2a study design was a double-blind, placebo-controlled study with a single ascending dose panel design. Participants were randomized 4-to-1 to receive clesrovimab or placebo. Once the highest dose of 100 milligrams was administered to preterm infants, that same dose was given to full-term infants in the final panel that you see illustrated on this slide, titled Full-Term 100 milligram. Please note that placebo recipients were randomized to each dose group, but when I show you the results, you'll see the placebo results aggregated in a single group. Also, please note the small number of participants that were planned to be randomized into the 20 milligram dose group. That will also become pertinent when I share results with you. So the primary endpoints were safety and tolerability, but additional important evaluations included PK, serum neutralizing activity, anti-drug antibodies, safety through at least 1 year, and active RSV surveillance with the collection of respiratory symptoms during the RSV season, as well as healthcare visits and nasal swabs for PCR testing of respiratory pathogens. This table summarizes our participant disposition. As you can see, a total of 183 infants were randomized. The majority, that is to say 93%, completed the study. The most common reason for discontinuation was withdrawal by parent or guardian. And as you can also see, the disposition of participants was generally comparable across study groups. Turning next to our safety summary. In the study, there were no deaths, no discontinuations due to adverse events, no treatment-related serious adverse events, nor were there any treatment-related allergic reactions reported. The proportions of participants with any adverse event, solicited injection site adverse event, solicited systemic adverse events, or serious adverse events were generally comparable across all clesrovimab dosing groups, ranging from 20 to 100 milligrams, as well as comparable with the placebo group aggregated as I described to you previously. Let's turn next to a summary of the PK data for each of the different dose groups, plotted here 20 milligrams through 100 milligrams on a semi-log plot. The figure to the left shows the mean concentration versus time profiles for each dosing group through day 150, and you can see the approximately dose proportional increase in mean concentration of clesrovimab. You can also see a gradual decay in PK over time for all dose groups, consistent with the extended half-life. In both the preterm, that's the 20 to 100 milligram dose groups plotted, and the full term, that's the light blue plot for 100 milligrams in that group of infants. Now, I hope you can read the footnote, but what you'll note there is that there were only 2 infants sampled at day 14 in the 20 milligram dose group. That's why I highlighted the small number of infants in that panel to you at the start of this presentation. Also, please note that we are not plotting day 365 data on this plot, as the majority of samples at that time fell below the limit of quantification, and you'll see why that is on the next slide. So let's go into the PK data in more detail. In the 4th column from the left, you can see the median Tmax, or time to peak concentration, which was approximately 4 days. As you can see from the column labeled C150, geometric mean concentrations remained high through the time point of interest, day 150, given the typical duration of an RSV season of about 5 months in temperate zones. Clesrovimab demonstrated an extended half-life of about 45 days across all dose levels, as you can see in the final box that I've given you for the final column. If you now focus your attention on the results in the bottom 2 rows, you can see that this extended half-life was observed in both preterm and full-term infants alike. Let's turn next to our anti-drug antibody results. The proportion of infants who received clesrovimab with anti-drug antibodies was 13.1% through day 150 and 22.8% through day 365. If you look at the figure to the right, ADA status, negative or positive, did not appear to have an impact on half-life through day 365. Moreover, there were no serious adverse events or safety signals associated with ADA positive status. Finally, let's look at the serum neutralizing antibodies. Here, we're showing the serum RSV neutralizing activity both prior to, at day 150, and at day 365 post-dosing. The figure to the left shows the serum neutralizing antibody titers on the natural log scale for each dosing group. Of note, for the placebo group, we had 38 participants. As I mentioned, it's a summation across all 5 panels. It's important to note that the baseline sample at day 1 was taken prior to administration of clesrovimab, so the neutralization activity that you're seeing there is coming directly from the host. Consistent with the neutralizing mechanism of clesrovimab, SNA titers increased in a dose-dependent manner through day 150, and you'll see here a 16 to 23-fold increase in SNA titers at that time point relative to baseline following the highest 100 milligram dose in preterm and full-term infants respectively. The increase in SNA titers in the 20 milligram dose group beyond day 150, and please keep in mind there were a total of 6 infants here, were from a sample at the day 365 time point of 2 infants. and we believe that this was due to RSV exposure in their second RSV season for these two infants. Please bear in mind that infants with confirmed RSV infection were not excluded from this analysis. All other dose groups saw a fall in SNA at the day 365 time point, consistent with this being at about 8 half-lives out for this monoclonal antibody. So this is an exploratory efficacy analysis from this small 1B2A study. It shows the results for incidence of RSV medically attended lower respiratory infections observed over the 150-day surveillance period for clesrovimab and placebo recipients placed side by side in tabular format. Please keep in mind the 4-to-1 ratio of clesrovimab to placebo. What we see in this exploratory analysis is a point estimate of efficacy to prevent RSV MALRI when all dose groups of clesrovimab were summed, 20 to 100 milligrams, of 74.2%. When you limit that, and please look now to the bottom row of the table, to the 100 milligram dose group given to the preterm and full-term panels, this observed efficacy is 80.6%. Now, this is a 1B2A trial. The sample size is small, and necessarily the number of RSV MALRI cases is low, hence the 95% confidence intervals are wide, as one would anticipate. And for those of you who attended the Lisbon RSVVW, these numbers will look very familiar, and that's because all of the efficacy data had been collected by the time of the interim analysis. We also looked in the similar exploratory fashion at our efficacy against acute respiratory infection and hospitalization, both for the combined dose groups as well as for the 100 milligram dose administered to the preterm and full-term infants. And you see those results summarized here with the RSV hospitalization endpoint showing a very high efficacy, but again, the case counts are small, the confidence intervals are wide, and this is a 1B2A study. What's important to us here is that it really gives strong motivation for the 2 phase 3 studies that are currently in the field. So, in conclusion, by way of summary, a single dose of clesrovimab was generally well tolerated in infants with a safety profile comparable to placebo, and a half-life of about 45 days was observed. Anti-drug antibodies were seen in a minority of participants with no apparent impact on PK or safety. Clesrovimab administration was associated with a dose-dependent increase in RSV SNA through day 150, and importantly, this first-in-infant study supported the continued evaluation of clesrovimab in our ongoing phase 3 studies. Thank you very much. Just wanted to take a moment, very important to thank all of the families and infant participants in our trial. It's no small matter to bring a small infant to a study site for all the visits and blood draws that the protocol demanded. This was only possible because we have stellar site staff, and we have stellar site staff because we have stellar investigators. So thank you to you all.
Thank you, Anusha. My co-chair has a question first, and then after that.
No, just congratulations on all the work so far, and when do you expect the readout from your 2 phase 3 trials?
Yeah, so both of our lead clinical directors for those 2 trials are in the room. Wish they were up here with me. And we anticipate those readouts later this year. We're hoping to be able to submit to ID Week. We'll see what the abstract review committee says.
Hi, Anusha. Great talk. I was wondering, looking at the half-life, and especially at the T max at only 4 days, do you have any idea, maybe in animal models or something, if this antibody is trapped somewhere and what we're measuring in serum is not necessarily representative? Mm-hmm.
That's a very interesting question. I direct you to a publication that came out last year by our discovery team led by Kalpit Vora. And here they took advantage of early phase data where not just serum PK, but also nasal PK data were collected. There were nasal epithelial fluid samples collected that enabled nasal PK to be measured. And what they saw here is that this molecule has a very interesting quality. It has a very high peripheral volume of distribution of well over 3 liters, which is más o menos double what other molecules in this class have. And this is because it has a high proportion of partitioning into the nasal compartment. So you're dead on in general where you were going with your thinking, and I can point you to both Culpeth and the publication after the talk.
Thanks.
Thank you, Anusha, for the nice talk. I'm Harish Nair from the University of Edinburgh. I was just wondering around your case definitions for preterms, and you've used 35 weeks or more as a cutoff for term. Obviously, that is not what is used generally in clinical practice or in an accepted definition. So a large proportion of the births across geographies, where we call them preterm births, are between 35 and 37 weeks of completed gestation age. So what proportion of your term babies in your quote-unquote term population were these sort of 35 to 37 weekers?
There were relatively few, but to get you the exact numbers, I'd need to look at the laptop. So Harsh, let me go ahead and do that after this talk. I know the table I need to pull, but I can't pull the number up for you. But it was a very small number.
Congratulations on this first study. We look forward for the phase 3. My question is, for those children that had breakthrough infections versus the placebo that had natural infection, were there differences in their neutralizing antibody response or immunologic responses, let's say at day 150?
So the 3 babies that had RSV Mallory at day 150, their SNA, Tony, it's an outstanding question. And again, I have the data on my laptop, but I don't want to say the wrong thing, and I'm not pulling it to mind immediately.
Okay, thank you.
Hi. So I'm Lucy Warter from GSK. I was wondering whether you sequenced the virus rescued, from the cases that you had in the clesrovimab treated groups, and whether you identified any variation within the antigenic site 4.
Right. So in our late phase program, both phase 3 trials are performing that sequencing, and so we will have a deep bank of sequencing data available from phase 3, not this trial.
Thanks.
So thank you very much, Anusha. And the first part of this session is now closed. We have a poster break for evolution and epidemiology. Please be back in an hour because we will start part 2 of this session. Thank you all.
Please take your seats. So before we resume, only one important housekeeping message. We will be having the WHO RSV road announcement, and after that will be the Barney Graham award ceremony. So please stay here until the end and before the lunch, because it will be one of the very important moments of the meeting, okay? So I will control all of you. I have now memorized your faces, and I will be sure one by one that you are all there by then. So Ruth, Jacob, the floor is yours.
Thank you, and welcome back to this very, very interesting session where we've heard a lot about the vaccines and antivirals. We'll continue with that. We'll be listening to Moderna talking about their RSV candidate. Over to Dr. Rita.
Thank you so much. Good afternoon. I'm Rita Das, the head of respiratory vaccines at Moderna. Thank you to the organizers, and I will be presenting 2 talks today, but very quickly. I will talk first about mRNA 1345, the first mRNA-based RSV vaccine. I'll present the efficacy and safety in older adults through 9 months of follow-up from our phase 3 study. Then I will show you our work in the phase 3 program and how it could be used to identify a correlate of protection for mRNA 1345. We have our immunogenicity as a poster at the conference, which I encourage you to visit. These are my disclaimers and the acknowledgements, and now finally the presentation. mRNA 1345 is a lipid-encapsulated mRNA-based vaccine that encodes the RSV fusion protein stabilized in the pre-fusion conformation. We saw robust immunogenicity in terms of neutralizing antibodies to RSV A and B in phase 1, which were detectable through 12 months post-vaccination. An observation in that phase 1 study is still ongoing. Our pivotal trial enrolled more than 36,000 healthy adults aged 60 and older, including those with chronic stable medical conditions and those who were vulnerable or frail. We enrolled at 269 sites across 22 countries. Participants were randomized 1-to-1 to receive a single dose of saline placebo or mRNA 1345 and are to be followed for 12 months. Randomization was stratified by age and the presence or absence of CHF and COPD. We also included pre-specified analyses of efficacy by the comorbidities listed here. The study enrolled individuals with frailty as measured by the Edmonton Frail Scale. The 2 co-primary endpoints were protection against RSV lower respiratory tract disease with 2 or more or 3 or more signs and symptoms. Protection against RSV disease, RSV-associated acute respiratory disease, or ARD, was a key secondary endpoint. Now, analysis from the symptom data that we've talked about here from the Rochester cohort found that having shortness of breath drives patients with RSV to seek a higher level of care. We use this symptom to measure severe disease in an exploratory efficacy analysis. So here are the signs and symptoms that comprised our case definition. On the bottom is all of the symptoms which qualified for that broad ARD endpoint. And on the top is the subset for LRTD. Identification of a symptom or a sign prompted a visit to the site and a nasopharyngeal swab, and cases had to be confirmed by RT-PCR. In light of the unpredictability of RSV seasons following the COVID-19 pandemic, we conducted continuous year-round weekly surveillance throughout our study period. So in the pre-COVID RSV seasons, RSV typically occurred in the months of November through May each year in the Northern Hemisphere. And I'm showing this in the US data in the graph here with the blue shading for the pre-COVID seasons. Now, during the pandemic, the onset of RSV shifted with cases occurring earlier and the season lasting a bit longer, as seen in the orange line. Again, this is US data. There also was a 2-fold increase in hospitalizations in adults 65 and older. Now, vaccinations in our study began in late November 2021 and continued through December 2022. Our primary analysis in light blue was driven by accumulation of a target number of cases. Success was declared at this time, but the study continued with a blinded team. Now, when all study participants reached 6 months of follow-up, an additional analysis was conducted in preparation for U.S. filing as agreed with the FDA. This is shown in the green line. The median follow-up here was almost 9 months, with a range from 15 to 530 days, so more than 17 months, and covering 2 RSV seasons. So the results of the primary efficacy and safety analyses were recently published in the New England Journal of Medicine, showing 83% efficacy against RSV-associated LRTD endpoints. So today I will focus on the results of the more recent additional analysis. Demographics were well matched between the vaccine and placebo groups. 62% of participants were in the 60s decade, 30% were in the 70s decade, and almost 3,000 were over 80. Race and ethnicity were evenly distributed, and approximately 30% of participants had one or more of the pre-specified comorbid conditions of interest. 16% were vulnerable, and 6% were frail. Presented here are the solicited local reactions. The most common local reaction was mild injection site pain. Other local reactions were also mild and transient, with onset 1 to 2 days and lasting a median of 1 to 2 days. There were few grade 3 reactions, which are indicated in orange. Here are the solicited systemic reactions within 7 days. The most commonly reported systemic reactions were headache, fatigue, myalgia, and arthralgia. Like the local reactions, the onset was 1 to 2 days and the duration was the same. Grade 3 events, again, were infrequent, as seen by the orange bars on the bottom. Now, unsolicited adverse events occurring within 28 days after injection. These were relatively balanced between the 2 groups. There was 1 death in the vaccine group, which was not considered related by the investigator, and there were 6 deaths in the placebo group. There were no reports of Guillain-Barré syndrome or acute disseminated encephalomyelitis, and there were no safety concerns identified for other neurologic conditions, including Bell's palsy or facial paralysis. And no imbalance was seen in cardiac arrhythmias, including atrial fibrillation. We looked also at myocarditis and pericarditis, as we always do, and there were no myocarditis cases in the vaccine group, and in the placebo, and as for pericarditis, there was no pericarditis with onset within 42 days of vaccination, which is a conservative risk window. Now here are the efficacy results through the extended period of follow-up, including the unusual 22-23 RSV season. Recall the median duration of follow-up was 8.6 months, with a range up to 530 days, more than 17 months. The efficacy of mRNA-1345 against RSV-associated LRTD and ARD remained high, with overlapping confidence intervals to the primary analysis estimates. Vaccine efficacy against LRTD with 2 or more symptoms and 3 or more symptoms was 63%. Efficacy against ARD was 54%. For all 3 endpoints, the lower bound of the 95% confidence interval exceeded 20%, which was the predefined success criteria for the study. Now, in concordance with the epidemiology data and what was seen by others, there were many cases that were accrued in December 2022. The cases were evenly distributed with respect to time since vaccination. In other words, the cases which occurred in the vaccine group were not occurring in vaccinees who were given the vaccine the farthest away from December 2022. So this, combined with the durability of immune responses from phase 1, gives us the confidence that efficacy is maintained. Now, the question of revaccination is an important one, since we've heard that protection from RSV by natural infection is not lifelong. But additional durability data will be needed to determine the timing. And we are studying revaccination at 1 and 2 years in our phase 3 studies. Breaking down efficacy by subtype, efficacy against both RSV-A and RSV-B was observed with overlapping confidence intervals for the estimates, and there were fewer RSV-B cases in the study. Efficacy by subgroup with respect to age, comorbidities, and frailty were also generally consistent with the overall efficacy. The data for those 60 to 69 and 70 to 79 actually show exactly the same efficacy with increasing age. In those 80 and older, the case numbers are too small to make conclusions. Paradoxically, in our trial, the over 80 group had the lowest incidence of RSV, compared to 60 to 69 and 70 to 79, perhaps a carryover of pandemic measures in these oldest trial participants. Finally, we assessed the impact of mRNA-1345 on preventing severe RSV, as indicated by shortness of breath, and efficacy was 74.6%. More participants in the placebo group sought a higher level of care, emergency room or urgent care, and there were 2 participants who were hospitalized, both in the placebo group. One was 73 years old, the other was 84 years old, and both had a history of asthma. There were no hospitalizations in the vaccine group. To conclude this part of the talk, our data show that mRNA-1345 was well tolerated with an acceptable safety profile in adults greater than 60 years of age. This was shown in more than 36,000 participants who had completed at least 6 months of follow-up. No events of GBS or ADEM were reported. Efficacy was maintained with protection against lower respiratory tract disease and the broader category of acute respiratory disease over the period of observation. The data also suggests that the vaccine prevented severe RSV disease as measured by shortness of breath with a favorable hospitalization and ED and urgent care data. Okay, so now that we've set the stage with the efficacy, we'll turn to the correlate of protection. The correlate analysis was pre-planned in the study design. Serum samples were collected from all study participants at baseline and day 29. A subset of participants were then selected to make an immunoset, which was tested for the 2 RSV neutralizing antibodies, RSV-A and B, and the binding antibody against the pre-F protein. Special thanks to the US government-supported CoVPN Biostats team, Dr. Peter Gilbert and colleagues, who we worked collaboratively on analyses methods for COVID-19 correlate of protection, and these are the methods that we applied here today. Now, to plan a case cohort immunosubset, the immunoset was selected from 7 cohorts listed here to ensure balanced representation of the study. This included people with risk factors, people from different geographies, as well as people from different age strata. Additionally, since we collected samples from all participants, we had samples from all ARD cases to include in this immunoset. Before moving to the biomarkers and endpoints, we worked through the baseline factors. Here are the baseline covariates we selected, and we explored if any of these baseline covariates were correlated to each other in a high degree. This would be seen in a blue number close to 1. Any correlated factors were then included just once in the model. The baseline risk model was established using SuperLearner, a machine learning algorithm procedure, which uses cross-validation to create a weighted average of multiple machine learning models. The performance was assessed using area under the curve. In the placebo, we see the AUC was 0.6, which means that the confounding factors don't have a big impact on the outcome. When we fit this to the vaccine group, we saw the same result. Now let's look at the biomarkers. On top is day 1, and the placebo and the vaccine group are completely superimposed. On the bottom is day 29, and we see a clear separation of the immune responses in mRNA 1345 red and the placebo in blue. We see this for RSV-A, RSV-B, and the pre-F binding antibody. Now, before going into the Cox model, here's the relationship of the cumulative risk to the over time compared to the biomarkers. And so the cumulative risk is on the y-axis, time is on the x, and all the three biomarkers are labeled. In gray is the placebo group, and you see that that risk increases over time. And on the red is the vaccine group, and the red is actually divided into 3 tertiles. And the highest tertile of antibody response is on the bottom, and you can see the highest tertile has the least risk for RSV disease. So this generally indicates that neutralizing antibody and binding antibody is a promising candidate as a correlative risk. Now is the Cox model. And this is adjusted by the baseline risk factors. The yellow highlight, the model contains only the treatment vaccine as a factor. You can see that the hazard ratio is significantly below 1, so the vaccine is a protective factor. When we add the biomarker to the vaccine, we see that the significance goes away. So this means that the biomarker explains the effect of the vaccine. On the right now, we see the biomarker alone and no vaccine. And you see that each biomarker individually predicts protection, very much like the vaccine. Now here are these results put another way, and in the interest of time, I'm just going to talk about the top 2 panels, which talk about the RSV-A neutralizing antibody. On the left is the correlative risk with cumulative risk on the y-axis and RSV-A neutralizing titer on the x-axis. Again, the red is the vaccine, the blue is the placebo. You can see as the titers rise, the risk falls. And the fit line for the risk for the vaccine, which is that line in red, overlaps the fit line for the risk in the placebo, which is the line in blue, indicating that neutralizing antibody is mediating RSV risk in both vaccine and placebo recipients. On the right is how now the antibody titer could be used to predict vaccine efficacy. And that fit line is increasing efficacy with increasing antibody titers. So at some point in the future, we could potentially use the mRNA 1345 titers to estimate vaccine efficacy. So with this analysis, overall, we're confident that the immune response by mRNA 1345, measured either by neutralizing antibody or binding antibody, is protective and a correlative risk. And perhaps in the future, these titers could be used to predict vaccine protection. Now, thank you so much for your attention. And this work would not have been possible without all our investigators and our study site personnel, as well as our clinical and laboratory personnel, and most importantly, the individuals who participated in the trial. With that, I'll take any questions.
Thank you, Rita. And before I have a question for you.
Yes.
This is about the first part of your presentation. Do you have data on the second half of the first year? You had up to 12 months. Between 6 and 12 months, what is the efficacy that you were seeing for the vaccine?
Yes, so we divided up the efficacy that way. For RSV-A, it was exactly the same. For RSV-B, it was slightly lower, but by that, in that second half bin, the case number for RSV-B also became very small.
Hi, very nice presentation. I had a question on the correlates analysis, and it looked like you were sharing the data based on the 2+ LRTI endpoint. So I was curious if you've done the same analysis for the 3+ or the more severe endpoints and how that impacted your hazard ratio.
Yes, so we have done the 3+ endpoints as well. Because there are fewer cases, the precision is less, but the trends are exactly the same with the 3+ as well.
Okay, thank you.
Hi, Lauren Harrington, GSK. Thank you so much for the presentation. I also have a question on the very interesting correlative protection data that you shared. If I understand correctly, you have some phase 3 analyses with different time points of serum antibody testing. So did you look at any other of those time points in that correlative protection study? And did it still come out with the same results?
Very good question. We are actively investigating this right now. We haven't finished our 6-month or 1-year testing, but that is on the docket to come off soon.
Okay, looking forward to it. Thank you.
Thank you.
Hi, Rita. Nice talk. I was wondering if you had cellular data collected for your trials and how, if you were to put that as a biomarker, how would that fit in? Because in the elderly, there is a concept that people accept that T cells may have a larger role to play than just the antibodies.
Yeah, no, that's a great question, Kalpit. So we have cellular data from phase 1, which is actually quite promising, both CD4 and CD8, and we have it out to, I believe, 6 months. We did not collect cells. We collected serum in every single person, but we didn't collect any cells. You know, even I think this also goes to show that that the neutralizing antibody, even if it's not the mechanistic protective factor, it may be correlated with what is mediating protection.
Hi, thank you. Just a short question about the correlative protection and correlative risk. I see that you have taken into account only RSV-A neutralizing antibodies, and I was wondering why you haven't shown anything on RSV-B antibodies.
Yes, I think just for the simplicity of the presentation, I was showing you the RSV-A and the binding. RSV-B was actually quite well correlated, and actually it was the best correlated for the RSV-B cases. And so, you know, while RSV-A seemed to mediate was correlated best for both A and B, RSV-B was best for B. So I showed A, and then pre-F was actually good for both as well.
Thank you.
All right, thank you very much.
Thank you. For the next one, we have vaccine efficacy and waning values from an adjuvanted RSV vaccine from GSK. Daniel will be talking to us. Over to you, Daniel.
Hi, my name is Daniel Molnar, Global Value Evidence Lead for the RSV older adult vaccine at GSK. And today I'm going to present on behalf of the GSK study group. The presentation will be about the vaccine efficacy and waning values from the adjuvanted RSV pre-F3 vaccine clinical trial. This is the slide with the disclosures, acknowledgements, funding, and conflict of interest. RSV is contagious with infection resulting in acute respiratory illness in all ages. According to Fauci et al., it occurs in 3 to 7% of the healthy older adults and in 4 to 10% in adults who are considered at increased risk of severe RSV outcomes. In 2023, the FDA and EMA approved RXV, the adjuvanted RSV pre-F3 vaccine, for the prevention of lower respiratory tract disease caused by RSV in 60 years and older. At the time of registration, we had data from the first season of our RSV-006 efficacy trial. However, since that, new data has become available from the trial and has been published. I'm sorry, I would need some technical help here. Thank you. Thank you. So at the time of registration, we had data from the first season of our RSV-006 efficacy trial. However, since that, new data has become available from the trial and has been published. Here on the slide, you can see results for the primary efficacy endpoint, RSV-LRTD, and the key secondary endpoints, severe RSV-LRTD and RSV-ARI at different follow-up time. The RSV-LRTD vaccine efficacy was 82.6% in the first season, almost 81% with a 14 months median follow-up time, and 74.5% through 2 full RSV seasons. Severe RSV-LRTD efficacy was 94.1% in the first season, almost 87% with 14 months follow-up time, and close to 83% with an 18 months median follow-up time. RSV-ARI efficacy was 71.7% in season 1, 63% in mid-season 2, and 62% with a follow-up time of 18 months, covering 2 full RSV seasons. These clinical trial results have been used to inform our current analysis. In this post-hoc analysis, we followed a stepwise approach to derive the peak vaccine efficacy and monthly waning rate from the clinical trial data in order to be able to project vaccine efficacy beyond the 18 months median follow-up time of the 006 clinical trial. First, we obtained monthly data in the vaccinated and placebo arm on the number of subjects, the number of RSV-ARI and RSV-LRTD cases, and the follow-up time in days. We have excluded severe RSV-LRTD from this analysis due to limitations with the number of cases. After obtaining the monthly data, we have aggregated time points based on a predefined criteria to have at least 8 RSV cases in the placebo arm. We did this to increase the robustness of the analysis. And with this approach, we have identified 10 time points for the RSV-LRTD and 13 time points for the RSV-ARI. We then calculated vaccine efficacy for RSV-LRTD and RSV-ARI for each of these data points as 1 minus the relative RSV incidence in the vaccinated versus the placebo arms. Here you can see the vaccine efficacy for RSV-LRTD at the 10 time points following 1 dose of the adjuvanted RSV pre-F3 vaccine. At each time point, we had at least 8 cases in the placebo arm, and the bigger the size of the bubble, the more cases we were observed. On this slide, you can see the RSV-ARI vaccine efficacy for the 13 time points following 1 dose of the adjuvanted RSV pre-F3 vaccine. Again, at each time point, we had at least 8 cases in the placebo arm, and the size of the bubbles indicate the relative incidence in the placebo arm. So the bigger the bubble, the more cases we had at that time point. As a next step, we have fitted a linear regression model on the efficacy data presented on the previous slides with the bubble charts. The linear regression model draws a line through the efficacy data points that minimizes their overall distance from the line. We performed a weighted least square regression analysis. This means that a weight was assigned to each data point, and it was determined by the number of cases in the placebo group. So the data points with the bigger bubble contributed with a higher weight to the regression analysis. The intercept of the regression model provides the peak vaccine efficacy, and the slope provides the monthly waning rate. For uncertainty test, a bootstrap procedure was performed with 1,000 samples to estimate the 95% confidence interval around the peak efficacy values and the monthly waning rate. On this slide, you can see the weighted linear regression line fitted on the RSV-LRTD efficacy values. And on this slide, you can see the figure with the weighted linear regression line fitted on the RSV-ARI efficacy values. The equation of the linear regression line provides the intercept and the slope again, which are the peak vaccine efficacy and the monthly waning rate, respectively. And this is what you can see on this slide. The peak vaccine efficacy for RSV LRTD is 88% with a monthly waning rate of 2.1%, meaning that at the start of the vaccination, the model estimates the highest efficacy for RSV LRTD is 88%. That decreases by 2.1% each month moving forward in time. The peak vaccine efficacy for RSV ARI is 74.2% with a monthly waning rate of 2.3%, meaning that at the start of the vaccination, the model estimates the highest efficacy for RSV ARI is 74.2%. That decreases by 2.3% each month moving forward in time. You can also see the lower bound and upper bound values for the peak vaccine efficacy and monthly waning rates obtained from the bootstrap analysis. We use these lower bound, upper bound values to test uncertainty around the point estimates. Here on the slide, you can see the peak vaccine efficacy and monthly waning rate depicted on a chart. 88% peak efficacy for RSV LRTD at month 1 and 2.1% monthly waning rate. And 74.2% peak efficacy for RSV ARI at month 1 and 2.3% monthly waning rate. However, in the first months, we assumed 50% of the peak vaccine efficacy. This is according to the clinical trial design, in which the follow-up period started 15 days post-vaccination. So we have halved the peak vaccine efficacy in the first months when we use these inputs in our public health impact and cost-effectiveness models. Waning is then applied as of month 2. The solid lines on the chart represent the trial follow-up time, and the dotted lines represent the efficacy projected with the regression model. In summary, our models suggest that one dose of the adjuvanted RSV pre-F3 vaccine could potentially provide protection beyond 2 RSV seasons. As soon as new data becomes available from the 006 trial, with additional follow-up time, we will update our analysis. And with that, I would like to thank my colleagues for their support in conducting the analysis and for your attention as well.
Thank you, Daniel. Any questions from the floor? But I have one. So in your regression, did you adjust for season or for calendar time?
In the regression model, we have not adjusted for that because we are using the actual monthly data. So
would the prior exposure be adjusted for? I mean, have any of your patients have had multiple episodes?
Yes, there were some cases, but we did not adjust it for season as covered.
Thank you.
Yeah.
Thank you for that excellent presentation. You did not comment on whether the regression, the decay, was comparable between RSVA versus RSVB. Can you comment there?
We haven't done the test between RSVA and RSVB, so we use the overall efficacy values from the clinical trial. We haven't done that test.
Okay. You'll have that data though, right?
We have that data, yes.
I think it'll be important to understand whether you see significant differences between one versus the other.
Thank you for the recommendation. We will consider that.
Thank you, Daniel, for this wonderful presentation.
Thank you.
So next we're going to hear from Iona Munjal from Pfizer Vaccines, Protection Against Infant Illness with a Bivalent RSV Pre-F Vaccine in Pregnancy.
Thank you so much. We were very privileged to be here last year to present our data, so we're very grateful to the organizers for having us back to present our 2 abstracts on the protection against infant illness with a bivalent RSV pre-F vaccine in pregnancy and our final analysis. Myself and some of my co-authors are employees of Pfizer, and our investigators are trial sites funded by Pfizer through our Matisse Phase 3 pivotal study that I'll be discussing today. We're absolutely thrilled, like all of you, to have some tools against RSV now. The RSV pre-F vaccine that I'm going to be discussing today is now licensed for maternal use under the trade name Abrysvo and has received licensure in these countries. We're very thrilled to have licensure in Argentina, and additional licensure in LMICs will be coming in the forthcoming year as part of our global filing plan to help reach global distribution. So I don't think I need to go into the burden of RSV disease, but a little bit about our vaccine. It's a stabilized RSV bivalent vaccine that can elicit polyclonal vaccine-specific antibodies. And we showed in our phase 2 data that there's a significant antibody protection, significant antibodies through 6 months of age in infants born to mothers vaccinated with RSV pre-F. We're going to highlight the efficacy data from the final analysis, which was consistent with our preliminary analysis data. In the pivotal phase 3 trial, we vaccinated pregnant participants between 24 and 36 weeks gestation, and were randomized 1-to-1 to receive RSV pre-F or placebo. Just in a reflection from the primary analysis to the final analysis data that I'm going to be presenting today, the primary analysis was the basis of licensure, and we had that analysis in September of 2022 specifically in order to have the vaccine available for the current 2023 RSV season. Over 97 of the participants were involved in the primary analysis, and you can see from the maternal participants in blue and the infants in purple, there were few but additional analyses that I'll be including in this final analysis. So what we got from the September 2022 until the conclusion of the study in October of 2023 this year was extended follow-up data in the infants, with about half of them following for 2 years. The Matisse study had a global footprint in 18 countries with over 7,000 participants enrolled from both maternal and infant participants, and we had participants in both the northern and the southern hemisphere. Key countries with their enrollment contributions are represented here, and we had a significant contribution of over 30% with LMICs, with over 4,000 maternal and infant participants representing those countries. The demographics in our maternal participants were well balanced between the two groups and representing our global and diverse population. For the maternal participants, the age at vaccination ranged from 14 to 47 years. Adolescent pregnant participants could be included. We think that's an important data generation point for both this study and our subsequent maternal vaccine studies. The gestational age at vaccination was between 24 and 36 weeks, and we obtained a significant number of maternal participants vaccinated in each of those gestational age groups. When we look at the pregnancy outcomes, we see that they're well balanced in the global trial in terms of days between vaccination and delivery, which we see on average was about 60 days in both groups. The gestational age at delivery, on average, participants were term at 39 weeks between the RSV pre-F and the placebo groups, and they were well matched in terms of delivery outcomes. The majority of our participants did have vaginal deliveries, and the C-section and emergency C-section rates were well balanced. We had only one maternal death in the study and a comparable number of fetal demise in both the RSV pre-F and the placebo groups. I'll now look at the infant participant safety data. When you look at the adverse events in the month following birth, both overall and by specific adverse event groups, we see that it was well matched between the RSV pre-F group in blue and the placebo in gray. We do acknowledge that in certain individual groups, including adverse events of special interest and congenital anomalies, both which were systematically collected throughout the trial period, that you can see some numerical imbalances, but all were statistically similar across the global study. I'm going to delve a little bit closer into our birth outcome data, and specifically birth outcome data in terms of prematurity and birth weight. As you see, the vast majority of the participants in the trial were born term. The trial was conducted during the global pandemic, and the total number of premature infants did trend lower than participants that were their cohort in the, that were not enrolled in the trial. When we look closer, we see that of the preterm infants, we acknowledge, as others have, that there's a numerical imbalance in the total number of preterm infants, with 207 in the RSV pre-F and 172 in the placebo group. Among early preterm infants, there was also a small numerical imbalance. When we look at low birth weight or very low birth weight, a potentially more objective outcome of birth, we see that the gap between the low birth weight in the pre-F and the placebo group did narrow. And in our very low birth weight infants, we in fact saw an opposite trend in numerical values with 4 in the pre-F and 8 in the placebo group. When we look at preterm births by country, we are showing here countries with at least 5 preterm births, as not all countries represented preterm births in the study. And we saw that both overall the relative risk was matched, and it did vary by country. We did note that the highest number of preterm birth imbalance was in our upper middle income countries, with an imbalance in South Africa of 20 participants, of 39 in the pre-F and 19 in the placebo group. We then did a significant analysis into the infant outcomes related to prematurity, and we found that they were comparable in both groups. I've already showed you the numerical imbalance between preterm births between the RSV, pre-F, and placebo. And then when we looked at those preterm infants who were also low birth weight, we found that they were better matched between the pre-F and the placebo group. Overall, if you looked at APGAR scores in our study, they were generally favorable. Those among preterm and term infants were well balanced between the two groups. And then we looked at outcomes related to hospitalization. When we think about our preterm infants and whether or not they had prolongation of hospitalization at the time of birth or readmission within 30 days, we found that the cases were well matched in terms of hospitalization in the neonatal period, with 2.3% in the RSV pre-F group and 2.2% in the placebo group, showing that the outcomes were comparable across both groups, whether or not they were preterm or overall. Along the lines of that, we looked at infant overall deaths and those by subcategory, delving into this further to see if there were any adverse outcomes in the study related to infant mortality. The total number of deaths that could have ranged from any time from birth until up to 2 years in the study was numerically favorable, with 8 in the RSV pre-F and 14 in the placebo group. We had a single infant with a death due to RSV under 3 months of age. That infant was from Japan and was in the placebo group. In terms of preterm deaths among infants who were born less than 37 weeks at the time of their birth, there was 1 case in the RSV pre-F and 2 cases in the placebo group. That same infant that was born preterm also died within 30 days after birth in the RSV pre-F group, and we had an additional 2 cases for a total of 3 neonatal deaths in any infant within 30 days after birth and 5 infants in the placebo group. The low mortality in their study probably reflects, as I've told you, the high gestational age at birth for most infants. And in fact, that's due to the timing from vaccination through to delivery among both preterm and term infants. By and large, our infants who are both preterm and term were born in over 30 days after vaccination. And you see in the 7 days following vaccination, we had 3.9% in the RSV pre-F and 5.2% in the placebo group. Similar trends were seen among term infants, and they were not born proximal to vaccination. This is a graphic representation of that, showing the timing of vaccinations in our study starting at 24 weeks all the way to 36 weeks, and the timing that you see of the births relative to those vaccination among RSV pre-F in blue and the placebo in gray. As you can see, from the time in our study when we started vaccination from 24 weeks all the way up to 32 weeks, we had approximately 4,000 maternal participants vaccinated with no imbalance in prematurity during that period. Imbalances that were seen in the study were numerical and late in the study and close to term. We did extensive additional analyses of maternal factors to see if there was anything to explain this numerical imbalance that was not occurring near to vaccination. We acknowledge regional variations between our high-income and our upper-middle-income countries in which we saw the strongest imbalance. These included maternal practices such as difference in non-study vaccinations and later ultrasounds. And this is consistent with antenatal care, but they were well matched between the RSV pre-F and the placebo group. There were some maternal factors that had minor differences and were higher in the RSV pre-F group, such as COVID-19 infection or a history of preterm births, but these numbers were overall low, and most maternal factors were well balanced between the two groups. Maternal adverse events of hypertensive conditions were reported more commonly in those in preterm birth, and were more commonly seen in the RSV pre-F group. Like prematurity, these tended to occur more than a month following vaccination. We've already started to conduct our pharmacovigilance studies looking at safety in the post-licensure period. We've identified no additional adverse events of concern, and these studies are all ongoing as countries start to implement the maternal vaccine. Now going to switch to our infant efficacy in the trial, which was followed for up to 2 years after birth. We showed high efficacy against RSV-positive severe medically attended lower respiratory tract illness, and this data is consistent with the primary analysis data that we had the pleasure of showing you last year. For infants, for their 3 months after birth, the final efficacy showed over 82% efficacy for infants and was sustained to cumulative efficacy of 70% for a period of time for 6 months following birth. I'm going to now show you that graphically. You'll see the placebo in the gray and the RSV pre-F in blue, and you'll see the cumulative number of cases along the bottom in that period of time from birth all the way out to 6 months. Now I'm going to show you this same graph, but instead of cumulative efficacy, I'm going to show you incremental cases. We conducted the study during the global pandemic with year-round maternal recruitment. This is important because babies were born in and out of the RSV season, and some had their first exposure to RSV later in life, and potentially at month 5, 6, or even later. And what we see here with the incremental cases is not only were we able to accrue cases each month to analyze vaccine efficacy, but in that interval from 5 to 6 months, we're still seeing incremental efficacy of 67% against severe medically attended lower respiratory tract illness. And this tracked very well with those significant antibodies that we saw in our phase 2b study extending out to 6 months of age. If you look at 12 months, and as I said, we had looked at both 12 and 24 months, we do have cumulative efficacy over that time, but we really are acknowledging that the efficacy during that time is driven by the first 6 months of age. So after 6 months of age, the efficacy is really balanced between those two groups, and we're not seeing efficacy beyond 6 months of age that is significant for the overall trial participants. Now, if we look at less severe medically attended lower respiratory tract illness, by and large, our infants during the trial were kept out of the hospital and in clinician offices. And during that time, these patients could have presented to any type of healthcare setting, but had lower respiratory tract illness. Among those infants that had less severe disease, we had efficacy of 57.6% at 3 months and 49.2% at 6 months of age. This is a similar Kaplan-Meier curve to what I showed you for the severe disease, tracking less severe RSV-positive, medically attended lower respiratory tract illness out to 6 months. Similar to the cumulative efficacy that I showed you before, I'm now going to show you the incremental cases, really to hone down. So, one of the things that we are really trying to pursue in this longer analysis study is, are those antibodies that we saw in the phase 2b study between 5 and 6 months achieving efficacy? And in fact, they did, with incremental efficacy for only those infants who were first exposed between months 5 and 6 at 46%, with cases, as you see, accruing newly every month throughout the study period. Hospitalization was a tricky metric during the COVID pandemic with many disruptions in typical pediatric care. So our all-cause hospitalization endpoint really reflected anybody that was admitted to the hospital, including those infants potentially who were dehydrated or had social reasons for admission. So looking at hospitalization, all comers with RSV during the trial, we had 55% efficacy out to 6 months of age. And if you looked at, for example, severe in hospitalization, we see efficacy go up to as much as 64%, reflecting that if you have lower respiratory tract disease and hospitalization, you're more likely to be protected with the RSV pre-F vaccine given to the moms. So in a summary of our final analysis, the results that I'm showing you are very similar to the preliminary analysis that we presented last year, having had the bulk of the data submitted for registrational study, with very strong efficacy seen not only in 3 months of age and 6 months of age, but in incremental efficacy out to those time periods as well. RSV pre-F in the overall trial was safe and well tolerated by maternal participants. We had the numerical imbalance in preterm infants in upper middle income countries, with an additional 9 preterm infants represented in the final analysis that I showed you here. Infants had overall good outcomes in the study, whether or not they were preterm or term infants. We obviously couldn't do maternal trials without an absolute village, and we really would like to acknowledge them now. The tremendous care that all of our study sites took with our participants cannot be undervalued. And at Pfizer, we're so privileged to be able to conduct these clinical trials with such a special group of participants. So we really give them our thanks. And I'd be happy to take any questions.
Thank you so much, Iona. Questions? Yes, Heather.
Thank you, Iona. Fantastic presentation and very reassuring. So there's a lot of debate around the age at which immunization could occur. You didn't show gestational age at vaccination by outcome in terms of prematurity. So under 32 weeks versus over 32 weeks. We know, for example, there are different approvals for lower bound of immunization in the United States versus the rest of the world. Could you comment on that? And then I have a second question which relates to, in low middle income countries, mothers are having babies often very frequently. What would you recommend for a second year in terms of immunization?
Yeah, thank you so much. So regarding the 32 weeks gestational age, so the outcomes were good whether or not you were born under 32 weeks or over 32 weeks. As you saw by the cadence in the trial, we actually had no imbalance under 32 weeks because by and large, the time period of prematurity was not close to vaccination. So we had no adverse outcomes. So the adverse outcome split that we saw, the numerical imbalance in the overall study population, didn't even occur till after 32 weeks gestation, reflecting that whatever was driving this was not proximal to vaccination as a trigger. And then your question regarding, the subsequent vaccination. So, we've heard all this lovely data from the adult studies, and it's such a different process mechanistically. And what we see from the phase 2b data, and we're actually analyzing the neutralizing titers now from the phase 3 data, so we look forward to presenting them in INMIS next month, is that the infant participants are having excellent transplacental transfer over 1, and they get a massive load of neutralizing titers at birth. And that's important because we have about a 42-day, decline in antibodies, right? That's our half-life. So when you look at that massive load, we really want 6 months. As you saw, to have that good incremental efficacy, we do really feel that it's important to have that maximum antibody level at birth. And so we're really looking at every pregnancy with 24 to 36 weeks being the optimum timeline.
Thank you so much for the talk. Very interesting results. So I was wondering if you looked for the safety for the preterm birth rate at other vaccinations during pregnancy, and so if you have that data, especially COVID vaccine, and if that happened before your intervention or after your intervention, so to look also at the temporality, causality with other vaccinations during pregnancy.
Yeah, thank you very much for the question. So as I described, there were variances among regions. For example, our tetanus compliance in low-income countries was very, very high. And we had overall in the trial in both high and low-income countries, over 60% of our maternal participants received non-study vaccines during the pregnancy and the antenatal period. Between the RSV and pre-F groups, though, those were matched. So those variations that we saw by region were matched between the RSV pre-F group.
And did you look at the association with the preterm birth?
And with the preterm group, they were well matched between the RSV and the pre-F group. Yes, both overall in the study and by preterms. We looked at those extensively for all the different vaccines. Yeah, we did note that in our trial, they were lower than historically reported. The trial was conducted during the COVID pandemic, but we do reflect that the trial participants had a higher number of vaccines than we saw in other studies.
Lovely talk. My question is similar to Heather's and refers to this multiple pregnancies. So because you were following these families for over 2 years, do you have any empiric data on whether any of the women had a second baby, not yet having received a second vaccine, and whether there was any efficacy for that follow-up birth?
So we didn't collect systematic data on subsequent pregnancies. All the maternal participants were consented and enrolled for the 6 months following birth. There was a very small number of them who had second pregnancies during that time period, and unfortunately a small number of those who had spontaneous abortions, and those were well matched between the two groups. But we didn't have other data because they didn't go to term during the time period at which they were consented from birth to 6 months of age. Any related pregnancy adverse events from any pregnancy would have been reported back to the trial, and we had no related second pregnancy adverse events reported.
Thank you.
Mm-hmm.
Hi.
I think we'll take 2 more questions, and Tony, I might just ask you to step aside because you've been able to ask a lot of great questions, more in the midst of. Sorry.
Hi, I have a comment and a question. It's wonderful that you have conducted this trial in COVID-19 pandemic, but in your analysis you have shown that the babies were exposed to RSV a little late. So this is just a hypothetical question. If this would have been done in a non-pandemic AD, do you think it would have any effect on the vaccine efficacy?
Yeah, that's a great question. So, what we see based on our neutralizing titers is that they're highest right at birth in the period of 3 months at birth. So when we see, typically during a typical season, that's when the bulk of the RSV infections will occur. So, in sort of practice, traditional sort of post-clinical trial practice, we hope that actually even more infants may benefit from the vaccine during that period of time when the antibodies levels are so high. For example, in the first month following birth, the vaccine efficacy is 90%, right? So when you see that shifting during, traditional use, and so we're looking forward to our post-licensure data to look at the efficacy and what it would be in a real-world setting. Thank you.
Thank you.
Hi, Jefferson Jones with CDC. Thanks for the talk. It went by a little quick, so I'm trying to confirm, when you said looked at VE beyond 6 months, it looks like on the slide there were numbers above 0 for those, but I thought I heard that you did not find any VE beyond 6 months. Is that because it wasn't statistically significant, or could you expand on that?
So the vaccine efficacy goes flat beyond 6 months of age. So when we look at efficacy, as I showed you both cumulative efficacy and incremental efficacy. There's no incremental efficacy beyond 6 months of age. What we think about is that there's a variable amount of titers that infants are getting at birth, and by 6 months of age, that variable amount is probably above average, above protection for most infants, because we're able to prove efficacy in the general population. Beyond 6 months of age, we see that there's individual titers potentially, when we've done modeling, potentially some infants remain very high after 6 months of age, but we weren't able to show it in the global population. So it is likely that that protective threshold in our general population dips below what could be achieved to demonstrate efficacy in a clinical trial.
Thank you so much, Iona.
Thank you.
So we'll now move on to the last talk of our session. Dr. Danny Feiken from WHO is going to tell us about the RSV Roadshow.
Okay, so I realize I'm the last one standing between you and lunch, so I promise I will be short. So this is a bit of a left-hand turn from all the great talks on the science we've heard this morning, but it is related because I can guarantee you that the people making decisions about introducing these new products that we've heard about in countries, particularly in low and middle income countries, are probably not sitting in this room. And so we've got to figure out a way to translate the science and the results to the decision makers. So I'm going to talk briefly about something that we've worked with several groups to develop called the RSV Roadshow, and in particular a communication toolkit that can be used to advance the RSV prevention conversation and reach decision makers. So I think it's pretty clear to this room why the time is right to have something like this. After decades of ups and downs, we suddenly have this explosion of products, and yet there still is a lack of awareness of RSV in most of the places that have the most severe disease. So we've got to figure out a way to communicate and reach those audiences in global, regional, and countries who make the decisions about RSV prevention, and that's what this toolkit is all about. So we're coming to you today as RSV experts, a technical community. You do have a valued voice, and you also probably have a lot of interactions in countries with clinicians, with professional societies, with public health decision makers. So we encourage you to
if you have the opportunity, give a talk about RSV, and this toolkit gives you a talk about RSV and RSV prevention, and so we make it easy for you. It even has scripts that you can use, so you don't even have to make up your own words. So the toolkit starts with something called the primer. This is about a 30-minute presentation on RSV disease and prevention. It's available, it's been translated into almost all of the WHO languages, which include Spanish, French, Portuguese, Arabic, and Russian. It can be given as a standalone talk if you have limited time. I'm showing you some slides from the toolkit so you can see what they look like. They look nice. There's been a graphic designer that's assisted. So the primer slide set talks about the global disease burden, which you've heard about, particularly the disparity in low and middle income countries where 98% of the RSV deaths occur. It goes through the new products that are available, particularly for infant protection, and the new products that are in the pipeline and when all of these products might be available. And it goes through some of the implementation considerations. So for example, for the maternal vaccine, which we just heard about, there has to be a union of the immunization departments and the maternal newborn child health departments because these vaccines need to be given in antenatal care clinics. So beyond the primer, there are some deeper dive modules that go into particular topics. These can be used as mix and match. You can see the topics covered on the right in these modules. There's clinical disease in early life. There's health economics, maternal immunization and long-acting MABs. How do they work? And in particular for RSV, what are the products available? What's the global disease burden? How do you address policy decisions and financing? How do you get these products delivered in country? How would you do surveillance if you wanted to for these products in your country? And then there is one slide set on prevention of disease in older adults, which hopefully will come later in many of these countries. This shows you some slides from the modules. This is one on clinical disease. So what is RSV disease? Where does it infect infants? How does it cause disease? What are the sequelae? What are the treatments? There's one on health economics. So how much does RSV disease cost in a country? And what do the cost effectiveness analyses show in lower and middle income countries? Here's one on how does maternal vaccination work in general? What's transplacental transfer of antibodies? How do these long-acting monoclonals work? And in particular for RSV, it goes through the roller coaster history of RSV vaccine development as well as highlighting the key breakthroughs that have allowed this explosion of products that we're seeing and give some timelines for when these products will be available. So all of these materials are available at this website. As I mentioned, there's not just the slide sets, there's scripts, there's information sheets. They're available at this website that is maintained by PATH, and you can download them. You can ask for a version that can be edited, so you can do your own thing if you want. There's a table outside. You can get more information, and fortunately the two people who have done the most to develop this toolkit, who are Jessica Fleming and Laura Newhouse from PATH, will be sitting there. We hope that later this year we'll be able to work with the RSVNet Foundation in giving a webinar series of all the modules targeting the appropriate audiences. And I want to thank the groups that you can see at the bottom right here who have developed some of these modules. I want to also thank Gates Foundation for funding this work and encourage you to think about giving a talk and contacting us if you want some of these materials. So thank you and enjoy your lunch.
Thank you so much, Danny. My suggestion would be that if people want to talk more about the roadshow materials, that they find you at lunch and potentially go to the PATH booth. I think that might be best. unless anybody, doesn't look like anybody has a burning question. No, Louis? You might. Do you have a burning question? No. Okay. So I think, excuse me, right. The Barney Graham Award. So Louis, over to you. Sorry about that.
So thank you for staying here. I want to acknowledge the work of two people. And before I turn to the Barney Graham Award, you may show the slide, I want to thank one person who could not be here, unfortunately, who is Deb Higgins. She was the person that started the RSVVW conferences. Was not ResVNet. The first person was Deb, and she is with PASS. She has been instrumental for the field of RSV vaccine development. Everybody knows her, the snapshot that she developed, and the ResVNet is very, very grateful to everything she has done. She retired from PATH, and we wanted to acknowledge her with a specific award that I will make sure through the people from PATH who are here that is going to be given to her personally. So even though she's not here, I would like to ask you to give her an applause. And then, as always, during every RSVVW, since about 5 years, we have the Barney Graham Award ceremony. Somebody who has been inspiring, research-minded, and has a heart for education. Barney was the first one to get this award. Unfortunately, he's not here to actually hand over the award because of personal health issues that you have been informed about. 3 years ago, Harish Nair won the award, and last year, Jason McClellan was awarded with the Barney Graham Award. This year, we have awarded somebody who started to work on RSV long ago, who has fought for LMICs forever. A modest person, an educator, a mentor for many young people, and a person who authored more Lancet or New England papers on RSV than anybody else. And I have a few words specifically for Heather. Please come up here. Dear Heather, I know how much you hate this moment, but thank you for standing here with me. Heather is the chair of the Department of Pediatrics and Child Health at the Red Cross Children's Hospital. And her work has focused on childhood respiratory diseases, including pneumonia, tuberculosis, asthma, and HIV-associated lung diseases. Come here. She has developed a strong clinical translational research program, establishing several clinical research sites, building a core clinical research facility, attracting substantial funding from international grant agencies, and mentoring many postgraduate students. She has established a novel African birth cohort study, the Druckenstein study, Druckenstein Child Health Study, to investigate the early life determinants of respiratory diseases in childhood. She is an NRF A1 rated scientist. She has published more than 350 peer-reviewed publications, has substantially contributed internationally, currently mentors or has mentored 50 PhD students. She is immediate past president of the Pan-African Thoracic Society and serves on the Forum of International Respiratory Societies. She received the World Lung Health Award in 2014, and in 2018 she was awarded the L'Oréal UNESCO for Women in Science Laureate for Africa and Arabia. How about RSV? 36 publications, more than 4,000 citations, including the 2016 Lancet Respiratory Medicine publication on the Drakenstein study, really a sentinel paper. You described that 23% of pneumonia cases in children were related to RSV. At a personal level, Heather, you've been a role model for me. You're passionate about global health inequities, and you've always given the same opportunity, you've always fought to give the same opportunities to every child in the world. You're highly engaged in education. We have worked for 20 years on educational platforms. You remember the Bronchiolitis Academy a long time ago. We co-authored 10 publications together, including 5 Lancet papers. You have been very good to me. Thank you for that. And last year we were part of the Matisse trial, which was also very nice. So this year, the RSV Barney Graham Award is for you because of your major contribution to global child health, the RSV community, both as a scientist, an educator, and a role model for many of us. You can open it. Yes, please do.
Well, I'm really at a loss for words, but now I am, and I'm just overwhelmed and completely, what a great honor and what great recognition from you and from this expert group. There are so many people sitting here and sitting in the world who have done such extraordinary work in RSV, and I think I've just been a small cog in that. And, you know, thank you for this acknowledgement. Thank you for the acknowledgement that our teams and our collaborators and the broader community have done. And thank you for championing low-middle income country children and children everywhere. This is what I take from there. Thank you so much.
Enjoy your lunch and be back at 20 to 3.
Session, another really exciting session ahead, and a really important, sorry, can I ask people to take their seats, please? It's great to see so much discussion going on. But let's start with the afternoon session, a really important session, implementation of RSV interventions. I'm going to ask our 2 co-chairs, Joyce Nayero and Jessica Fleming, to please come up. They're both probably well known to you. Joyce is an epidemiologist in tropical and infectious diseases working at the Kemri Wellcome Trust research program in Kilifi in Kenya. And she's done a lot of work in microbiological identification of children with lower respiratory tract infection and in guiding policy recommendations for RSV, preventive interventions. And Jessica Fleming is also well known in infectious disease epidemiologist and senior scientist working at PATH in Seattle, Washington, who's worked in the field for the last 25 years, I think. So wonderful to have Joyce and Jessica with us, and if I can ask them please to lead into the session. Thank you.
Hello, everybody. My name is Jessica Fleming, just introduced. Really happy to be here with you and happy to be co-chairing this session with my esteemed colleague, Joyce Nayero. You know, over the last 2 days, we've heard about the significant burden of RSV and the phenomenal science behind the development of the new breakthrough prevention products. The 3 lectures in this session are going to focus on what is often an equally formidable challenge, but one that's often overlooked or underestimated, and that's the decision-making, introduction, and routine delivery of these interventions at the country level. We have a lot of experience to build upon in delivering vaccines to pregnant women and birth dose interventions to newborns. But RSV will likely present both new opportunities and challenges that will require advanced planning and coordination between the maternal child health departments and the immunization programs. Our first lecture, given by Dr. Rose Jalongo, will focus on the delivery mechanisms of monoclonal antibodies and maternal vaccines through the healthcare system in Kenya. And following this, Rosemary Njugo will share her team's experience developing a maternal immunization readiness assessment tool for healthcare facilities in Kenya. And then to round out our session, Dr. Pradeep Haldar will share his perspective on rolling out new vaccines in India. If we don't use up the 15 minutes in each of the presentations, we're happy to take a couple of questions, but we do have time at the end of the session for question and answers. So to begin with, I will welcome Dr. Jalongo. Dr. Rose Jalongo is a medical doctor who has built her career around vaccinology and public health program management. She's the head of the National Vaccines and Immunization Program with the Ministry of Health in Kenya. She has vast experience in spearheading successful planning and introduction of various vaccines in Kenya, including malaria, influenza, yellow fever, HPV, and COVID-19 vaccines. She's a member of multiple technical working groups, such as the Kenya National Vaccine Safety Advisory Committee and the very important Kenya National Immunization Technical Advisory Group. And she served as an advisor to WHO in the development of the framework for the allocation of malaria vaccines. And for all of you young researchers out there, you'll be happy to hear that she also actively participates in teaching and mentoring students. So really happy to have Dr. Jalongo with us. Thank you.
Good afternoon, colleagues. I'm happy to be here today to speak to the delivery mechanisms of maternal vaccines or monoclonal antibodies through the healthcare systems. So I'm going to be speaking as a policymaker. Again, we see how best the rubber meets the road once we are from the lab doing a lot of research, and now we want to do the implementation piece of it. So I know we know the power of monoclonal antibodies. Again, they are very precise and target specific diseases. And then they have the benefits of having actually rapid response and also control outbreaks. But as much as we do have them within our public health systems, unfortunately, we do not routinely give monoclonal antibodies. What we routinely give are vaccines, despite the fact that they are also very specific in terms of controlling disease. So when it comes to monoclonal antibodies for specific diseases, again, it is found mostly in the private sector vis-a-vis the public sector, and when it is needed, it is purchased at that particular time. So in terms of experience within the public system, the experience is actually very limited. So again, both vaccines and monoclonal antibodies, they protect the newborn. And examples of vaccines that we do have are tetanus, influenza, MMR. And again, we've seen evidence of how they reduce morbidity and mortality. But what we currently have within most of the healthcare system, we have tetanus, diphtheria in the public sector, And recently, we did deploy the COVID-19 vaccines, again, within the public healthcare system. So I know we've had tetanus diphtheria for a very long time. We can say more than 4 decades in Kenya. So again, in terms of experience, how we do give maternal vaccination, we can quickly point to the experience we've had with tetanus and diphtheria. As much as it's been there for the last 4 decades, unfortunately, the 5-dose vaccine, the uptake is not as good as we'd all think. So mothers come in their first visit and they're supposed to receive the first dose of tetanus diphtheria. So that is the highest coverage that we do have at the first visit. So probably less than 50%. And this is for a vaccine that has been here for more than 4 decades. As we progress to the second, third, the fourth, and the fifth jabs, the uptake is quite low. So again, I want us to know that the uptake is quite low for the other antigens, the other jabs that are given at the second, third, and fourth. But the first one is pretty high, but less than 50%. For the COVID-19 vaccines, when they were introduced, again, there was a lot of hesitancy, especially around the pregnant mothers. And the reason being is because in Kenya, or probably the African setting, when we have a pregnant mother, the decision-making around pregnant mothers, it's like a community affair. So if before any intervention is given to the pregnant mother, we have either the mother-in-law, the community, the society, having an input on what they need to do. So during the deployment of COVID-19 vaccines, we approved that the vaccines are given to pregnant mothers, especially either Pfizer or Moderna. But surprisingly, the hesitant group were the healthcare workers. They did not want to give the vaccines to the pregnant mothers. Reason being, they've been taught in school for a very long time that vaccines or interventions are not supposed to be given in the first trimester. So we do have an advisory from our NITAG. We do have the vaccines rolled out at the health facilities, but the healthcare workers hesitated to give the COVID-19 vaccines. Reason being the fear of what would happen if they give the vaccine in the first trimester, and then number 2, any adverse outcomes, they felt that they would be blamed for it. That is for the COVID-19 vaccines. For the tetanus toxoid, again, it's been there for quite a long time, but we still have challenges in terms of rumors and misconception. One, we've had several controversies in Kenya, especially either linking the tetanus toxoid vaccine with content of family planning or sterilizing women so that they cannot give birth. So again, even a vaccine like that has been there for quite a while, still has challenges in terms of public awareness and some of the rumors, myths, and misconceptions around it. So in terms of either vaccine, monoclonal antibodies, or how would you introduce maternal vaccines? So there are several things that we look at when we do new vaccines introductions, and particularly for the adult population, and that's particularly for pregnant mothers. So in Kenya, we use WHO pre-qualified vaccines. So as long as it's not WHO pre-qualified, it's not going to be used within the country. Secondly, the approval by the National Regulatory Authority. So this has to be approved in the country for use. And the processes of approval can take quite a long time, between 12 months to 24 or 48 months. So again, for any new vaccine that's going to be introduced within the next 2 to 5 years, this is the time to start discussion with the national regulatory authorities, again, because of the long processes that are involved in terms of registration. The third thing is that we may have guidance from the SAGE at the global level, we may have guidance at the regional level, but at the country level, again, we do have a framework for prioritization of vaccines that need to be introduced. One of the key things that the NITAG is going to look at is evidence or burden of the disease in the country, and the justification why we do need an intervention before any vaccine is introduced. So again, the discussions within the NITAG is going to be very important in terms of whether an intervention is introduced or not. So most of the time, either the country has generated the disease burden, or we have the surrounding countries with similar characteristics having that data. The fourth thing, again, that we have to consider is funding. Kenya, one of those countries in Africa, is funded by Gavi. So again, it depends whether this new vaccine or intervention is within the Gavi portfolio. Because again, most of the countries do co-fund their vaccines, especially the new and underutilized vaccines, with the support of Gavi. So again, looking into the context of any new intervention, we are going to probably look at the cost of introducing that intervention vis-a-vis other preventive measures that are currently there. So in terms of the opportunities and challenges that would have both for the monoclonal antibodies and also for the other new maternal vaccines, the RSV. So in terms of infrastructure, again, we'll have to prepare in terms of how prepared are we in terms of the existing infrastructure that we have. So the infrastructure can either be things like cold chain, capital investment. Do we have enough at the national level, the sub-national level, and even at the health facilities? And then the other infrastructure that we may look at, for example, for the monoclonal antibodies, we do not have any prior experience within the public sector, either of storage or setting up systems to administer monoclonal antibodies, to do any documentation, and also any storage. So again, that has to be set up before any rollout is started. Then the other thing that needs to be done is decision-making for introduction. Again, countries have several priorities in terms of disease burden. So in terms of the RSV, where do countries rank in terms of the impact of the disease burden and the other adverse outcomes that it causes? The associated costs, again, when it comes to introducing new vaccines, majorly, we especially donor-funded countries. So where is the money that's going to do the operation cost, the vaccine introduction grants? Is it Gavi that's going to support countries, or countries are going to actually resource mobilize within themselves to introduce the vaccines? We do have monitoring and surveillance systems that we really have to think through. So one of the things that we do, especially for the childhood vaccination, is that, which most countries are familiar with, introducing vaccines during the infancy, is that we do a lot of passive surveillance, adverse events following immunization. As much as this the vaccines have been there for quite a while, the reporting for adverse events following immunization is still suboptimal as guided by WHO. So for pregnant mothers, again, the reporting for adverse events following immunization is quite low, not very common. So again, this is one of the areas that needs to be strengthened. Just talking to the healthcare workers and the mothers that they need to report any adverse events following immunization, especially when new vaccines have been introduced or even the existing vaccines. Then the fifth item is in terms of public awareness. How aware is the public of RSV, the causes of RSV, and also the available interventions? But the introduction of these interventions could also provide opportunities to strengthen maternal immunization platform. And this is how. If we, for instance, we reflect on how we can strengthen the existing maternal vaccination that's currently being administered across the countries, we have more opportunities to strengthen the new upcoming vaccines. So we have to still create awareness about the importance of completing the 5-dose schedule of tetanus diphtheria that has been there in the system for quite a while, and understand the challenges why mothers are not coming for all the doses that they are required to do. So once we understand this, it's going to build a better platform of introducing other maternal vaccines. Again, building into the lessons that we learned during COVID-19 introduction, especially to the pregnant mothers. We have an opportunity for integration. And this is where the opportunity lies. We got an opportunity during the COVID-19 pandemic to introduce vaccines to the adult population. So again, strengthening the adult platform or creating and learning lessons on how we can approach the adult vaccination platform. But now we are currently integrating the COVID-19 vaccines into the broader healthcare system. So in Kenya, we've developed guidelines of integration. And how do we integrate? We integrate with other programs within the Ministry of Health. So for instance, we've integrated with reproductive health, we've integrated with those programs, HIV programs, TB programs, because now the COVID-19 is focusing more towards adults, either with underlying conditions and pregnant mothers. So at the service delivery points, they've created a way in which the immunization program speaks to other programs, so speaks to reproductive health, speaks to the HIV program, and this is an opportunity for us now to leverage on this integration, life course approach to vaccination, bringing other programs on board so that we can at least have a wholesome picture in terms of vaccination. So in terms of the strategic delivery mechanism, again, we spoke about the infrastructure developments. We have to think about cold chain, transportation, documentation tools. How do we link this to what is currently existing? Affordability and also integration with other strategies, looking for strategic partnerships so that this can be rolled out at the service delivery points. Community must be key and at the center of any new intervention. So the community has to be involved, engaged. They have to give feedback on what they think would work for them. And again, the mothers have to contribute to some of the fears they do have so that the healthcare workers can listen and also allay that anxiety. We'll need to think outside the box in terms of if we need partnerships for progress. So we are not going to stick to the usual partnerships that we know within the immunization space. We have to look within the other departments within the Ministry of Health. Which other programs can we reach out to? We need to apply lessons from the other vaccines that have been existent for quite a long time. The new vaccines that are being introduced, we need to learn and apply lessons for us to be able to roll out any new intervention successfully. And again, engaging the communities, engage. Again, there are the key in terms of any intervention. So monitoring and evaluation and community feedback. So we have to also still strengthen the information system, passive surveillance, and engage with the community in terms of feedback. What is the community communicating? What do they want? How can we improve better? Data use for decision making in terms of how much vaccines do we get for the pregnant mothers? How do we plan for them? How do we budget for them on an annual basis? So I know that monoclonal antibodies and vaccines would offer a great opportunity to integrate these services with other health system areas. But immunization, we are looking at currently doing a life course approach to vaccination. And again, it's a very good opportunity to strengthen the maternal immunization platform. So this is a call to action to all the stakeholders that are involved either in research, education, media, and also the policymakers on how best can we collaborate for us to roll out these interventions in a successful manner. Thank you.
Thank you, Rose, for that stimulating presentation. So for the sake of time, we'll take all the questions at the end of this session. And I want to take this opportunity to invite the second speaker, who is Rosemary Njogu. Rosemary is a highly experienced nurse midwife with a master's degree in community health and development. Rosemary played a crucial role in the introduction of maternal vaccines COVID-19 in Kenya. So she's going to give a presentation on health facility maternal immunization readiness assessment tool. So she's working with JAPIGO in Kenya. welcome Rose. And we have a third speaker, Dr. Halder. If you are in the room, please come forward. So, welcome, Rosemary.
Thank you so much, and I'm delighted to be here today to speak to everyone in this room about the implementation piece of the maternal immunization. And I first want to mention that the Maternal Immunization Readiness Initiative project is Bill and Melinda Gates funded and implemented by Johns Hopkins, specifically IVAC, International Vaccine Access Center, jointly with JAPIGO. I'm an employee of JAPIGO, and I will be discussing more into the other piece after science, after we've produced the vaccines, and the vaccines are ready. So how do we deliver these vaccines to the mothers? How do we ensure the babies also get protected? And so, as you well know, just to refresh all of us, this is meant to prepare for maternal vaccines, and the project was specifically focusing on preparation for initially for COVID-19 vaccine, then RSV and GBS vaccine. And as you well know that these vaccines need, for them to protect the baby, they need to be given at the right time, not too early and not too late. And research earlier, the last 2 days, has shown this. I'll be presenting more the development process of a globally endorsed tool, which has been piloted and developed both in Kenya and Bangladesh, where the program was funded to support. So what was the key objective and scope for the health facility readiness tool? And even before I speak to the objective, the reason why the readiness work is key for us, it's because as much as the efficacy of the vaccine is important, so it is for the consumer to understand why they are getting the vaccine and when they should get the vaccine. And also the provider, the health worker, they need to understand when to give the vaccine and why they should give the vaccine, the cold chain of this vaccine. So that all boils into the preparation work for these vaccines. And looking into the overall objective of this project was to assess service delivery, that means availability and readiness, for us to be able to offer future maternal vaccines. Let's look into the guiding principles for this tool development, the readiness tool development. We decided not to invent the wheel. We decided to look into what's already there working, feasible, which one would be more the clarity part of it, and which would provoke the managers to take action. We looked into what tool would speak into the local context, and that's in this scenario we were looking at Kenya and Bangladesh, and looking into how can this tool be adopted for local context in low and middle income countries and also other countries. Looking into the quality of care, we're looking at the combination between provision and the experience of care. For this activity, we also focused more onto the experience of these health workers. So, more on the guiding principles, we looked into the antenatal and maternal health care, including tools for introduction of newer interventions, maybe e.g. ultrasound, immunization. We also looked into the already available tools, the Service Availability Readiness Tool by WHO. So how did we go on the process of developing the readiness tool? This tool, once in Kenya, we were able to select 25 health facilities, and these health facilities were from primary and secondary healthcare facilities, which are the bulk facilities offering immunization in Kenya. And we followed a very intense process where we were able to discuss with the national, the county, and we held meetings for them to understand why we need to assess the readiness. We selected sites for pilots. We also visited these facilities to interview the staff to be able to understand what is currently working. We held readiness discussions at these facilities, revised the tool jointly with the health workers to be able to speak into them. And the reason for this is we realized how much we introduced other maternal vaccines. As Rose mentioned earlier, it was paramount for health workers to understand the reason behind these vaccines and for them to get a buying in. And that's why we wanted a tool which speaks more into the health workers, a tool which can respond to their queries. So looking into this tool, it had around 4 subsections: service delivery and service availability, service readiness, quality of care, and health information system. I will go step by step on how we came to develop the tool. And as I mentioned earlier, we reviewed different tools which are already in existence, MOH consultations, and this basically we did at the national and county. Then we did the first draft tool. Then we had discussions at the national level. The immunization department, the reproductive department contributed to this tool. We did a non-research determination. We piloted the tool, then later consolidated the findings and took the tool back to the facility. And I would say what much helped in this process is we had reflection questions. And these reflection questions were looking more into the timing and length of the process, sequence and flow of the readiness tool, balance of interview, overall formatting. We got recommendations for the tool, and we also looked at duplication with other existing tools. From this, what did we learn? And to the conclusion of this, we learned that this tool, the readiness tool which we developed, was feasible at multiple levels in Kenya system, whereby after reviewing it with the ministry, we were able to adjust the flow, the timing. And I want to mention that the initial readiness tool we developed was taking 6 hours in the facility. Going for the pilot and reviewing and changing indicators with the health workers, we were able to reduce the timing to around 3 hours. That means it was more usable and it was friendly for the health workers by the time we got to the final tool. The tool was acceptable, and the findings were informative as pertains to responding to the country and the county managers. We were able to use the tool, and it was able to detect quite a number of gaps as pertains to readiness. A good gap which was identified by then is, by the time we were going to do the pilot, we realized we had fewer maternal child booklets where immunization data is recorded in Kenya. And so this we gave feedback to the ministry, and they were able to respond to it. We also realized that this tool would be able quickly to identify even what data was not clearly being recorded at the facility. And if the health workers were proactive in recording maybe the side effects, considering these are new vaccines, then we're looking into, would the tool be informative enough for them to be able to identify the side effects? The final version of the tool was reviewed jointly with the ministry, and the biggest lessons learned is engaging all stakeholders and incorporating input from the local facilities is crucial, despite the time and resources it may take in all these processes. And this is because this is the only piece of work which will be able to tell us if the vaccines already produced will be used at the facility level. And I want to give an example with the COVID-19 vaccine in Kenya. There was vaccine hesitancy because we would say there was no time. Being in a pandemic, we didn't have time to do facility preparedness. In Kenya, facilities are more integrated, so it was easier for us to introduce a vaccine. But let's look at the side of Bangladesh, where we also piloted this tool. We realized that in Bangladesh, the ANC and the children immunization is not integrated. So you realize there's more time taken by the mother moving from one department to another to go for immunization. So why should we assess readiness for these vaccines? We will be able to identify those gaps early enough. We will be able to say sites or services are not integrated, so we need either integrate the services or introduce more cold chain equipment to be able to cater for the mothers in their ANC units. Or we need to lower or disseminate the materials to health workers for them to integrate the services for the mother and the baby. We have already the adaptable tool, the health facility readiness assessment tool, uploaded in Align MNH. You can also scan the QR code and you'll get the tool. On the side, as we developed the tool, we realized we lacked, I would say, fact sheets to give the health workers information on COVID-19. And you can see those two beautiful fact sheets were developed after responding to the readiness. That's why we need actively prepare our facilities. As much as we want to produce the vaccines, then we need to go back and prepare our facilities to make sure we reduce the vaccine hesitancy and increase the uptake to reduce mortality and morbidity in the world. I want to take time to thank everybody who participated in the work, the donor, BMGF. We have Prof. Ruth, who also from the JHU, who participated in a big way in making sure that the MIRI project was there in Kenya and Bangladesh. Not forgetting the JHU team, also who participated in this, the Maternal Immunization Readiness Initiative Study team, and the MOH team in Kenya, including the reproductive and the immunization team in Kenya. Thank you so much.
Thank you so much, Rose. I think maybe you can stand there and take a few questions from the audience. Do we have any questions from the audience? I don't see anyone coming forth. Thank you, Rose. You can. So I think you realize we've just made a sharp twist from the usual talks we've been having since day one. So going forward, I'm going to invite our third speaker, who is Dr. Pradeep Halda. So Dr. Pradeep Halda is going to give a presentation on rolling out a vaccine in India. He worked as a national immunization manager for more than 16 years and has represented various technical bodies at international and national level. So welcome, Alda.
Yes, I thank RSVNet for giving me this platform to speak on vaccine rollout in India. And when we are talking about vaccine rollout in India, we always have to keep the scale and size. We look at almost 26 million birth cohort. We look at 29 million pregnant women every year. So that's the size that we always look at, looking at the part. I have no conflict of interest. If we really look at the roadmap of vaccine introduction in the National Immunization Program, we will look at from 6 vaccine preventable disease. We have now covering almost 12 vaccine preventable diseases. And specifically, if you really look at the last 1 year, I would say that TD vaccine was one which was also been introduced for the pregnant mothers, switching from TT vaccine to DD vaccine. So that's how the schedules look at. Whenever we talk about any new vaccine introduction, there are 4 things that we always have to keep it in mind, that we are looking at a new vaccine which is not there at all, or we are looking at a vaccine which is there, but it's basically switching the product from one to the another. That's a trivalent to bivalent, so on and so forth. or we are looking at a vaccine which was already there, but we changed the schedule from 1 dose to 2 dose and vice versa, or even the vaccine product. For example, when we were looking at the rotavirus, so we had liquid vaccine, and then came the frozen vaccine, then came the lyophilized vaccine, so on and so forth. So these are the 4 different types. So whenever we talk about introduction of vaccine, so we always look at what is exactly we are talking about for a new vaccine introduction. When we talk about the new vaccine introduction, we have a National Technical Advisory Group on Immunization. This was created way back in 2002, has been amended from time to time. It's an apex technical body for the Health Ministry, which provides the technical part, and it consists of various experts from different fields, including, I would say, cold chain experts, the modelers, the social scientists, drug regulators, apart from the other technical people who are form part of the NTAGI. It also includes the other experts, the ethical committees, the ethical people, the health economists, the nursing pharmacists, so on and so forth. And then there are the union ministries people who are the ex-officio members. So this is how the NTAGI structure is. And whenever we are looking at the NTAGI, it would look at both the national and international papers, guidelines, the SAGE, etc. So those are some of the documents that the NTAGI would look at it. And it is supported by the technical subcommittee, and the technical subcommittee is further supported by a subgroup on domain experts. So that's how the entire structure has been created. The domain subgroup would deliberate, the technical subcommittee would deliberate. There is no time limit for these 2 particular committees, where they have to finally make recommendations over a period, and then finally those recommendations come to the NTAGI. If we look at the new vaccine introduction, I would break it down into 3 different parts. One part is a technical process, where, as I said, the expert group, followed by the technical subcommittee, followed by the NTAGI, that's which makes the technical recommendations. Once the technical recommendations is made, it is then presented to the government, and then government would look at it in terms of the operational part, the financial component, the feasibility of introduction, etc. That's where the administrative process comes. And once that process is completed and approved, then finally comes the last part, is the implementation. And whenever we talk about the implementation, we again break down into 2 components mainly. One would be the vaccine experts. For example, which vaccine we need to introduce into the program. What will be the specifications? Because when we look at Government of India, it also procures vaccine. So what will be the vaccine specification that the Government of India would like to procure? So this expert committee would formulate that specification and really make it easy for the government to procure the vaccines. And once that happens, then comes the next part, introduction. As I said, we have almost 26 million birth cohort. We have 29 million pregnant women. We can't introduce the vaccine overnight in the entire country. It has to be in a phased manner. Phased manner would mean where first. And that's, we also have an introduction working group would look at it that, okay, this is the burden, this is where the burden is more in the country, this is the place where we should first introduce, and that is exactly this particular would be in. And on a long-term basis, would also look at the mid-term evaluation and impact of vaccine introduction. So the NTAGI basically would look at the burden of the disease, the incidence, the prevalence, the absolute number of morbidity, mortality, and both epidemic and pandemic potentials. It would also look at safety and efficacy of the vaccine, cost effectiveness of vaccination, and also the vaccination schedules and interchangeability. And when you look at the government administrative processes, its availability of domestic or external vaccine production capacity. So you can't have a discussion of an introduction without having the availability of the vaccine. Affordability and financial sustainability. So any vaccine which gets into the program, one needs to really see that the vaccine, there is an affordability and sustainability for it, and program capacity to introduce a new antigen, including the cold chain capacity. So the other operational aspects are inclusion of the EPC and MSG as a technical committee to constitute. So this is, I would say, a process wherein the technical body looks into it, and making the technical process and all. So it's just been elaborated in a much more detailed manner. Whenever we are talking about introduction of a vaccine, there are three clear processes one has to look at. Either we are looking at a campaign, that would mean we are looking at a cohort and vaccinating everyone, or we are looking at a routine introduction. Whenever we say routine introduction, that would mean at any time, let's say if we say it's a maternal vaccination, everyone between 24 to 34 would get the vaccine. So do we vaccinate everyone with 24, 34? So what would be that introduction process? Because the moment you do that part, you actually land up in a big campaign. So we don't want a campaign. So what we do is we then tag it with the existing vaccine so that there is a clear demarcation that whenever you tag up with that existing vaccine, the first dose of that vaccine would decide an introduction and second dose would obviously not get the vaccine. And then third would be a clear plan for a replacement so that an existing vaccine is there and you're replacing with another vaccine. So these are the three strategies that we really look at when we talk about a new vaccine introduction. I'm just looking into a rotavirus introduction. There are challenges when we talk about a new vaccine, and I've taken a rotavirus example. Whenever we have introduced a rotavirus vaccination, this is a BMJ article which clearly said one group, we should not introduce a rotavirus because it causes increase in intrusive system. The second group said, no, we should introduce a rotavirus. So if it is not based on science, this is the debate that we will face whenever we will introduce a vaccine. Similarly, court cases. So if it is not based on science, we again get into the court cases and then we have to struggle with the court for vaccine introduction. And then we are looking at, once that is approved, we need to develop the technical guidelines, the technical documents. We need to formulate the different documentations for the parents, for the healthcare givers, the IC materials and others. And once we have done that, we put it into place. So today when we look at the immunization program, I would say that the maternal vaccination has a common platform with immunization program. So wherever there is immunization, that's the platform where the maternal vaccination are being given. So there is no separate platform for maternal vaccination. That is a platform only maternal immunization will happen. So it's a platform where both child as well as the mother gets vaccinated. And these are some of the strategies which has been shown on the other side that we have been employing to improve the vaccination coverage. In conclusion, I would say the NTAGI recommends for new vaccine introduction and product interchangeability, if any, introduction to be supported by scientific evidence on efficacy, safety and program. Maternal immunization shares a common platform of child immunization, hence any strengthening of routine immunization also strengthen the maternal immunization. Vaccination schedule should match with the existing vaccine schedule so that we are able to co-administer the vaccine so that the child or the mother does not come back again and again. So, for example, the TD vaccination is one of the maternal vaccination, and if it co-administers with RSV, so that would definitely help. And then birth dose vaccination at the delivery point. So we have almost 80 to 85% in institutional delivery. So we are talking about that part because after the birth, the next contact comes at 6 weeks, that is 1.5 months. So the child's contact we lose that time, and then sustainability after introduction. It should not happen that you have introduced and suddenly then you realize that you are not able to sustain. Then post-introductory evaluation and impact of vaccine introduction. Thank you very much.
Yeah, I think we can now, thank you so much, Alda, for that presentation. We can take questions.
Hi, my name is Marta Tufet, and I'm with the Gavi Alliance. And of course, we're very interested about this stage, not only the procurement of vaccines, but how do you deliver them. And thank you very much for the 3 presentations. They're really enlightening. And I think we all understand that there's been a lot of investment that has gone into the EPI system since the 1970s, but as soon as you try and introduce a vaccine outside of that system, there are many challenges that need to overcome. And Rose, you mentioned the importance of integration with the maternal system, and I wanted to understand what do you think are some of the evidence gaps that we need to fill at the implementation level in order to prepare for this future RSV vaccine, for a future GBS vaccine, that we can start thinking about now, and that we can start coordinating with partners to ensure that we're filling some of those evidence gaps so that we have better chance at success of delivery. Thank you.
Yeah, I thought maybe we were asking questions to Dr. Halder, but now since they are general questions to the presenters, maybe Halder, you can come over and then we can have a Q&A session.
Thank you for that question. In terms of the current gaps that we have, as I had pointed out earlier, most countries, and Kenya is one of them, rolling out tetanus diphtheria. So the coverage for tetanus diphtheria is not where it's supposed to be. It's actually below 50%, and that's for Kenya at the national level. So there are some sub-national areas that definitely it's not doing very well. So before we introduce other maternal vaccines, we need to work on and ask ourselves the critical questions. Why aren't mothers coming for tetanus diphtheria vaccine? Why isn't the coverage 90%? So once we answer those questions, is it a health system factor or is it knowledge in terms of the mothers? And again, this is a vaccine that has been there for more than 40 years, and we still don't have a coverage of more than 80%. I think it's a high time we ask ourselves, why don't we have the coverage that we are supposed to have? And then once we answer those questions, we are in a better position now to prepare for other vaccines. Otherwise, if we introduce the other maternal vaccines, they are going to suffer the same low coverage that we do have.
Yeah, go ahead.
Jaya Goswami from Moderna. So I have a follow-up question for Dr. Rose and then Dr. Haldar. Great talks. So for DTP coverage, do you, so there are always differences between administrative coverage and serosurveillance coverage. Do you see serosurveillance as a tool to impact or increase DTP coverage in Kenya and in other parts? Serosurveillance using dried blood spots specifically.
So in terms of how we do our coverage, we do the administrative coverage, where we have the health facilities, all the health facilities that are offering immunization services, report on a monthly basis through the Kenya Health Information System that is reflected at the national level. So that has been rolled out nationally. However, for the serosurveillance, it is not a nationwide data collection system. We do have specific research institutions, for example, KEMRI, either based in Kilifi, Nairobi, or Kisumu, that does that serosurveillance. So again, I think it requires a lot of investment and infrastructure for it to be rolled out at a national level. So that's why it is population-based. So I think that's why we still go with the administrative data that is available across at almost all the service delivery points.
Thank you. And then for Dr. Haldar, so could you speak to how the task force was utilized during the COVID pandemic for adult immunization during the pandemic?
You see, during the COVID period, so we had created even a higher committee, what we call it NEGVAC. And NEGVAC was looking at the entire COVID vaccination, and it actually involved many of the ministries, including, I would say, the other ministries which is involved into the vaccine production, other industries which was involved into regulation component and other part, and also making a decision at the other end of looking at it. We also developed a digital platform, and CoWIN is one where all vaccination, so more than 2 billion doses has been given under the COVID vaccination and including the pregnant mothers and others. So this is all in the digital platform. So entire database is a digital platform, and in fact with the lesson that we have learned from the digital platform, we are now putting it into the UVIN. So we have a lot of, I would say, digital system into the place, like cold chain inventories are there, the entire vaccine supply chain is there, they are all into the digital platform. So the visibilities are all there for this entire digital platform. And I would say the NICVAC would also get, I would say every 10 minutes refresh rate was there. And they could look at it, what was the vaccination rate happening at the day at different centers, and they would take a call on how to improve the coverage during that COVID vaccination period.
And do you think that that will continue to other vaccines in adult immunization, not just pregnant women, like flu and potentially RSV?
Yes, I would say that if you are really looking at already the beginning has happened for the adolescent vaccination, where we have been talking about the TD vaccination and now the HPV vaccination. Decision has already been taken, so very soon we will see the implementation of HPV, and probably the other vaccination route will follow for adults and other part. But the digital platform already, as I said, has been gone into the UVIN, where entire the routine immunization component is now digitally recorded, and you don't give immunization card or you don't give other, the entire database is now in the UVIN.
Thank you. Yes, Etha?
Thank you for very interesting talks. So this is a question to Rose and actually to the whole panel. I mean, we're seeing an emerging number of maternal vaccines. There's DTaP, there's COVID, there's influenza that are all approved for pregnant women. We now, want to get RSV out there. How are we going to prioritize which one? Are we going to tell pregnant women to get 4 different immunizations? How does the timing of those work? Is there a priority we should be looking at, is my first question. And my second question is around documentation. I don't know about other countries, but in my country, South Africa, documentation of pregnant women vaccination status is really almost non-existent. And is there some mechanism to develop a life course vaccination card that in fact may also include pregnant women vaccination, adult vaccination, as we increasingly look to that?
Thank you. On how, I know there are several vaccines that are available for pregnant mothers. So how would we typically choose which ones to introduce? So one, I think it points down to the disease burden. So as a policymaker, what is the burden of this specific disease? And then are there any other interventions that can be able to be introduced apart from the vaccine? And if we introduce a vaccine, what is the impact of introducing that vaccine? Again, we are looking at it in the context of other competing priorities, especially other diseases within the country. So again, it always boils down to what is the burden of the disease and what is the impact of that intervention. So for instance, for tetanus diphtheria, we've introduced this because of the maternal and neonatal tetanus. And then we had COVID-19 that was introduced during during the pandemic period. So for RSV, do we have that data in the country to really demonstrate that if we introduce a vaccine, it's going to be beneficial to the country, it's going to lead to a significant reduction in morbidity and mortality? I think those are some of the questions that we need to answer. And then in terms of documentation, I do agree with you. We currently have different forms of documentation in Kenya. So we have the documentation for infants that has been there for quite a while. So we do have the mother-child booklet. And then we have for the mothers, again, who are pregnant, they use the mother-child booklet. But during COVID-19, we introduced an electronic system where you get vaccinated and you get like an e-card immediately. So what we are thinking about is how can we ensure that we have like a sort of a life course approach to ensure that all these documentations are streamlined together. Again, looking at how we can leverage on the technology that was used during the COVID-19 pandemic to ride on the other childhood immunization antigens that have been given. Thank you.
Thanks, Heather. I might just mention one other thing on the first point about prioritizing different vaccines. I think we've done work around acceptability of pregnant women receiving more than one vaccine at a time. There's definitely a dichotomy. Some women would prefer to get multiple jabs at once and get them over with, whereas other women are much more interested in getting one this visit and potentially another one the next visit. So I think the priority would definitely come in there. But I think building in some flexibility there in terms of, you don't want to push anybody away if they're not willing to get two at once, but maybe encouraging the woman to come back, I think would be good. There's also, of course, that push for all of you vaccine developers in combination vaccines, because as we add more and more vaccines, there are only so many vaccines people are willing to get at once, and I think this really is an issue for the monoclonal antibodies when we're looking at a teeny tiny newborn and we're already giving BCG and hepatitis B and multiple vaccines to just there's a finite limit of how many vaccines parents are going to be willing to give infants. So I think we need to be thinking of long term. Thanks.
Yes? Yeah, my name is Emmanuel from Perth. Thanks a lot to the presenters. I have two quick questions, one to Dr. Rose Jarango. We often get into challenges about introducing vaccines because of lack of the burden data. And of course, in your presentation, you are talking about burden data. For example, the HMIS now records pneumonia. It doesn't go down to the cause of pneumonia. Is it bacterial? Is it viral? And definitely, you cannot get information about if it's viral, if it's RSV or not. And now we are talking about a vaccine for RSV. So I'm just wondering if we might need, actually, we do need to change our HMIS into recording down to the details of RSV, because we get back into the issues of data every now and then, and it's usually a challenge. And how readily available actually is this RSV data in Kenya, for example? My other question is to Rosemary. Yeah, thanks again for developing the readiness tool. Every time we do introduce a vaccine in a country, we do readiness assessments, which take time and money and resources and all that. I'm just wondering, looking at the one that you've developed for RSV, how possible is it to integrate it with the WHO readiness tool for all the vaccines so that, we can adopt that and use that, generally speaking, without necessarily having one for RSV, having another one for typhoid, having another one for this. So how can we integrate that tool into one so that we can use it all together? Thank you.
All right, thank you. I do agree that more and more we are moving to making decisions, data-driven decision-making processes, but that becomes quite challenging, especially if we do not have data at a country level. So there are several ways that we do get data, again, for other priority diseases. We do have the Department of Disease Surveillance that conducts passive surveillance on a routine basis, and that again is used on several occasions to make decisions concerning the patterns of diseases. Secondly, we work with research institutions and sentinel sites, again, that do surveillance regularly, and again, that is part of the information that is used in decision making. What I foresee as a challenge with RSV, I think, is in terms of diagnostics. How do you diagnose RSV? And I think it's one of those things that, again, will be a challenge in terms of diagnosis and also reporting. So again, we may look back to our sentinel sites and also the research institutions within our countries. So having said that, a At times, what we normally use is either we look around the countries that have similar characteristics like Kenya and use the same similar data to make decisions if that is not locally available. But again, the call is how best can countries ensure that they do collect data that can be used to make decisions. Because any intervention that is being introduced is actually very expensive, and we need data-driven decisions so that we can prioritize in terms of resource allocation. Thank you.
Thank you. That was a very good question on how can we integrate and what are some of the, I would say, connection points for the readiness tool which has been developed under maternal immunization versus the other readiness tools. I would want first to specify that the readiness tool, which was piloted both in Kenya and Bangladesh, specifically speaks into the pieces which were left out in the immunization tool. That means the mother concept. You clearly are aware much of the vaccines in the low and middle income countries have been focused more to the children. And so when you look at the assessment tools for assessing readiness, they leave out the piece for the mothers. And the mothers' clinics in some countries are not integrated in the bigger immunization team. And so the reason why we need to include the maternal indicators specifically for the readiness work so that in future, then we can be able to get good information as we introduce the maternal vaccines. And I want to speak into this tool. One of the key gaps identified included the health workers' capacity to even be able to support mothers both for the vaccine work and the ANC work. Quite a few challenges. They are lacking the mother-child booklets in some health facilities. Having the advanced effects following immunization booklet, not in the maternal clinics. Yet we are introducing vaccines wholly for the mother. So those are some of the things I think as we move on, we need to incorporate them in the bigger readiness tool. Then integration will be better in future. Thank you.
Our time is up, but if you can be... Okay. So please, Baki and Harish, you can speak with any of the speakers, or we can still hear your question.
I think my thing was more of a comment than a question. I mean, I would like to hear from the speakers, but it's not individually directed at one person so this is more about, we are at a vaccines meeting and we are trying to develop new vaccines and improve coverage, right? I haven't heard at this meeting or in any of the previous meetings about improving delivery mechanisms, which is basically looking at patches, microneedles. How can we try and, get the end user to improve their uptake of vaccines? Because we are coming at a saturation point. I think already you've mentioned and others have mentioned, there's only so much that you can inject into one person or one baby's arm. And I think it'd be important to sort of reflect on this and do some formative work to see, because when we start modeling the uptake of vaccines, which the cost effectiveness modelers and others will do, then they would need to understand some of this, because without those kind of data, it becomes really difficult. And also for people like Dr. Haldar who are planning to see where, how this can be then rolled out. So I think it'd be helpful for everyone to sort of think around that. Over.
Yeah, thank you. Quick.
So very briefly, Harish has spoken to my first point. But my second point was just around the burden of disease data, which also links with, the peculiarities of vaccines working sometimes differently in different settings. It's just, what's the place of regional data? Our resources are limited. We're getting all this country-specific data. And in honesty, the boundaries between our countries are very artificial. What's the place of regional data in helping us to better use our resources?
Thank you. So after this, we have a poster session category vaccines, therapies, and treatments. So we'll come back at 16:45 for the next session. So if there's anyone who would like to maybe get more information from the speakers in this session, they are happy to meet with you. Thank you for your attention.